exam image based question, obviously nothing will be labeled, isn't it? Any idea about the slide you are seeing here? Which lymphoid organ you are seeing here? Exactly. This is thymus actually. Okay, thymus. So how I am saying this is a thymus, this is the histological slide of thymus is because, so thymus is surrounded by capsule, okay, but we are not able to see the capsule here. So thymus is surrounded, covered by capsule, okay. Thymus is surrounded by capsule, okay. And inside the thymus, you will be able to see, okay, just a minute. Okay, fine. Okay, so thymus is surrounded by capsule, okay, and if you see the interior of the thymus, you will be able to see trabeculae dividing the thymus into numerous lobules, okay. So thymus will be divided into numerous lobules, okay, and the lobules will be having, okay, each lobule will be having outer cortex. You can see the dark stained areas you are seeing in each lobule is called as cortex, darkly staining area because of aggregations of lymphoid follicles, okay. And inner lightly staining areas are called as medulla, okay. So thymus consists of numerous lobules which will be having outer cortex and inner medulla. Outer cortex is a darkly staining area, it is darkly stained, okay, darkly stained areas, okay, and the inner medulla is lightly stained areas, okay, lightly stained. You can easily appreciate in the diagram, okay, fine. And the most important thing about the thymus gland is you can see inside the medulla, do you see the numerous pink colored or pink stained masses? What are those pink stained masses present in the within the medulla called as? Yes, Husserl's corpuscles. Okay, so the identification point for the thymus is Husserl's corpuscles. Okay, Husserl's corpuscles are the characteristic features of thymus. Never forget this point. Okay, so what are Husserl's corpuscles? They are nothing but pink or eosin. Husserl's corpuscles are pink or eosin stained masses, and where they are present? Exactly, they are present in the which part of thymus only? Which part of the thymus? Is it present? Are they present in the cortex of the thymus or medulla of the thymus? Yes, medulla. Within the medulla of thymus. Okay, present in the medulla of thymus. Fine. Okay. So in this slide, this is the highly magnified view of the previous slide. Okay, so you are able to see the darkly stained area called as cortex, outer cortex. Okay, this is the outer cortex. Fine, this is the outer cortex, this limit. Okay, and do you see the medulla, inner lightly stained area called as medulla? And you can see numerous pink stained masses which I am marking. Okay, which I am marking. All these pink stained masses are called as Husserl's corpuscles. Fine. Okay, which are present in the medulla of the thymus. Fine. Okay. Now try to identify the slide. Try to identify which lymphoid organ has been shown in this slide. Yes, you are able to see the outer capsule, isn't it? And the interior, you are able to see the lymphatic nodules present in the cortex, and you are able to see the inner medulla. Okay, so tell me which organ has capsule and outer cortex and inner medulla. And remember, between the cortex and the capsule, there will be some spaces called as subcapsular. Just beneath the capsule, we have some space called as subcapsular. beneath the capsule. So subcapsular space or subcapsular sinus. Subcapsular sinus or subcapsular space. Okay. So tell me which lymphoid organ you are seeing here. Exactly. This is the slide of lymph node. Lymph node. Okay. Lymph node. So the lymph node is characterized by the presence of subcapsular. Okay, just beneath the capsule, the space is called as subcapsular sinus or subcapsular space, whatever. Fine. This is the characteristic feature of the lymph node. Okay. Actually, the subcapsular sinus will be filled with the lymph. It will be containing the lymph. Fine. And one more important thing we have to remember regarding the lymph node. Okay, lymph node is high endothelial venules. Okay, high endothelial venules are present in which of the following organ? That may be a MCQ question. High endothelial venules, HEV. Okay, high endothelial venules are present in which organ? The answer is lymph node. Normally, you know, endothelial cells are lined by simple squamous epithelium. Okay, simple squamous, flattened cells. Okay, but here in lymph node, the venules, okay, venules, they are lined by tall endothelial cells. Okay, that is the meaning of high endothelial venules. So remember, high endothelial venules are present in which organ? Lymph nodes, lymph nodes. And one more thing is paracortex. Okay, so between the cortex, okay, between the cortex and medulla, we have one particular area called as paracortex. Okay, which is the thymus dependent area or thymus. Sorry. Okay, leave this one. Actually, paracortex is the T cell dependent zone. Okay, instead of thymus dependent zone, make it as T cell dependent zone. Okay, because this paracortex is rich in T lymphocytes. It is rich in T lymphocyte. So it is called as T dependent zone because it is rich in T lymphocytes. You can see in this image. Okay. So actually, this is the capsule of the lymph node. Again, this is a magnified view of lymph node, slide of lymph node only. Okay. So you are able to see the capsule. Just beneath the capsule, are you able to see the subcapsular space or subcapsular sinus? Yes. And you are able to see the outer cortex, which contains the lymphoid follicles. And you are able to see the inner medulla, outer cortex, inner medulla. And in between the outer cortex and the inner medulla, particular area is called as paracortex or a paracortical zone, which is rich in lymphocytes, T lymphocytes. Fine. Okay. Let's move to the last slide. Okay, of lymphatic system. Okay. So can you identify which lymphoid organ is shown in this image? Yes, this is the spleen. Okay, this is the histological slide of spleen. So how I am saying this one is the slide of spleen? Because of the presence of thick capsule. Okay, the spleen is characterized by the presence of thick capsule. Fine, thick capsule. Capsule will be present in thymus and lymph nodes also, but spleen is characterized by presence of thick capsule. Is it okay? And if you see the interior of the spleen, it will be having red pulp and white pulp. There is no cortex and medulla in spleen. Spleen does not contain outer cortex, inner medulla and all. It contains red pulp and white pulp. Okay, spleen contains red pulp and white pulp. So what do you mean by red pulp? What do you mean by white pulp? See this diagram. Right now I am marking the lymphoid follicles, isn't it? The numerous lymphoid follicles, aggregations of lymphoid follicles. Okay, so these are the part of the spleen called as white pulp. So white pulp is characterized by the presence of lymphoid follicles, aggregations of lymphatic, okay, aggregations of lymphatic nodules or follicles, whatever. Okay, So lymphatic nodules with the central artery. With the central artery. Do you see the central artery here? I am marking as CA. Okay. Central artery. So each white pulp of spleen will be characterized by the presence of central artery. Okay. So this is how we will be defining the white pulp of the spleen. Okay. So white pulp of spleen is nothing but lymphatic nodules with the central artery. Okay. Although we call it as central artery, but it is located at the periphery of the white pulp. So eccentric position. Okay. Although it is called a central artery, it is occupying the eccentric position. That is, it is present at the periphery of the white pulp. Okay, fine. Remaining all the areas. Okay, right now I have told you the white pulp, isn't it? The remaining all the areas present in the spleen, these red colored areas are called as red pulp, which will be having the splenic cords and the sinuses. If you see this image, you will be having a clear idea. This is the magnified view of the spleen, isn't it? Magnified view. So as I told, this is the white pulp already labeled. So white pulp is nothing but lymphatic nodules with central artery, but having a eccentric position. Okay. So these are the two central arteries. These are the two central arteries. Okay. And remaining all the areas will be called as red pulp. Red pulp. So red pulp consists of two parts. One is called as splenic cords, which are having irregularly arranged lymphocytes, and another one is called as splenic sinusoids or sinuses. Okay, fine. And remember the another name for the splenic cords, they are called as cords of Bildroth. Cords of Bildroth. Okay, so the splenic cords are also known as cords of Bildroth. Okay, fine. So this is about the histology of spleen. Okay, so spleen is characterized by the presence of thick capsule, as we have seen in the previous diagram. Okay, spleen is characterized by the presence of thick capsule. Fine, and the interior of the spleen will be having two parts. One is called as red pulp, another one is called as white pulp. Fine, red pulp and white pulp. Okay, and what do you mean by red pulp and what do you mean by white pulp? You will be knowing, isn't it? What is the meaning of red pulp and white pulp? You will be knowing, isn't it? Fine. Now, one more important thing about the spleen is, you know, the central artery, otherwise central artery, okay, located in the periphery of the white pulp, isn't it? Surrounding the central artery, we have aggregations of lymphocytes, okay? These areas, aggregations of lymphocytes surrounding the central artery, okay? Those are called as pals. What do you mean by pals? Yes, they are surrounding the central artery, isn't it? So they are called as periarteriolar, okay? Periarteriolar lymphatic sheath. So if the question is periarteriolar lymphatic sheath is present in which of the following lymphoid organ? The answer is spleen. So I hope you know you have understood the meaning of periarteriolar lymphatic sheath. Surrounding the central artery, we have aggregations of lymphocytes called as periarteriolar lymphatic sheath. Okay. So PALS, simply called as PALS, present in spleen. Is it okay? And where do we have high endothelial venules? High endothelial venules. Yes, they are present in lymph nodes. High endothelial venules are present in lymph nodes. Where do we have Husserl's corpuscles? Thymus, fine. Thymus, okay. So that's all about the today's session. Okay. Thank you all. Thank you.
Good evening, friends. Today we will have one important MCQ for INICET, okay, which is based on our cardiovascular system. MCQs on cardiovascular system in medicine are more focused on this atrial fibrillation, atrial tachycardias, as well as the oral anticoagulants. These are the areas where they are focusing more nowadays. Okay, yeah, let's see this question. Yeah, in atrial fibrillation, they have given 4 statements and they are asking what are the true and false statements. Novel oral anticoagulants, the NOACs, are used in treatment of moderate to severe mitral stenosis. In moderate to severe mitral stenosis, they're telling NOACs are used as drug of choice. B. Patients with ischemic stroke due to atrial fibrillation, anticoagulation should be used. And B, C, NOACs are contraindicated in those patients with prosthetic valves. And D, all patients with atrial fibrillation who are candidates for cardiac surgery can be started on beta blockers. Who are candidates, okay? That's not, it's who are candidates for cardiac surgery can be started on beta blockers. So they're told all the statements are true, BCD true, ACD true, or D, ABD are true. Okay. So for this question, let's analyze what is happening in atrial fibrillation and what are the important concepts you should remember in terms of this NOACs as well as atrial fibrillation. Yeah, what is this? It's your left heart. Okay, so from your left heart, if you see in atrial fibrillation, what happens? Due to some mitral stenosis, where this valve is getting stenosed, your left atrial pressure increases. Okay, due to increased atrial pressure, the left atrium initially undergoes hypertrophy followed by dilatation. Okay, this usually happens in case of mitral stenosis. Then at one point, what happens is the atrium gets enlarged. Atrial hypertrophy followed by atrial dilatation. So at one point, atrium is completely dilated and it is not effectively contracting. So, and if the patient has features of high atrial rates like atrial tachycardias, atrial flutter, atrial fibrillation, in which the heart rates will be more than 400 plus or minus 50. So in such high heart rates, the atrium won't be contracting. The atrium will be just fluttering, fibrillating. Okay, it won't be contracting. So that means in that cavity of the atrium, blood is cooled. Okay, any areas blood stasis undergoes means it's a high source for thrombus formation as per Virchow's trial, which tells endothelial injury, stasis, as well as hypercoagulability as tried for thrombus formation. So in atrial fibrillation, thrombus forms as a result of stasis. So this thrombus showers as embolus into multiple systemic vessels. Like, see, their thrombus is getting formed and it is started to embolize into the systemic circulation. So if you see, it is embolizing into the cerebral circulation. Okay, to the CNS, I can embolize even to the GIT, all the systems can be affected. Renal artery, everything can be involved. So to prevent this, if you find there is thrombus in the left atrium, or if the patient has developed atrial fibrillation itself, that means it's a high source for thrombus to develop. So in any atrial fibrillation patient, if it is due to mitral stenosis or any structural heart disease, then how are you going to anticoagulate? See, this you should know. There are two options for anticoagulation. One is warfarin, and the next is novel oral anticoagulants like dabigatran, rivaroxaban, apixaban, 10A antagonist, as well as thrombin inhibitor, which is dabigatran. So, how to decide what to give when, and how to give decide the timing of this anticoagulation? Let's see that. So, next is first you should see whether it's an acute ischemic stroke. It means embolization has happened to the middle cerebral artery causing stroke. And if you find AFib is the cause, then how are you going to anticoagulate the patient? So in that situation, look for the BP. If it is persistently high, 185 more than 110, or if there are some large infarcts, like more than 2/3 of the MCA territory is involved, okay, or if there is high bleeding risk or complications of bleeding, like the patient is already having a bleeding disorder like hemophilia, or the patient is having some CLD, cirrhosis of liver with altered coagulation profile, where the patient is prone for bleeding, all these bleeding complication risk patients, like all active bleeding pepticles. So in those patients, if that is there, and if it is a large infarct, their anticoagulation you should not give, because already the patient is having bleeding risk. Or if it is a large infarct, meaning the infarct tissue at any time can undergo hemorrhagic transformation. If you give anticoagulants, that area will undergo hemorrhagic transformation. You should never attempt anticoagulation in such patients. Or BP is high, 185, 110. If you are giving warfarin, if in any vessel ruptures, that's all. Bleeding will be uncontinuous. The patient will die on the spot. So, is in such conditions you should avoid anticoagulation. If you have ruled out all these emergency conditions, you can go. The patient is stable. You start the anticoagulation, warfarin or Novax. Warfarin usually 1 day of onset of stroke, and Novax after 2 days of onset of stroke. We give. Okay, so stroke and atrial fibrillation we have studied extensively now. Now let's go and see what anticoagulation to choose in case of mitral stenosis. See, some 3 golden rules you should remember with respect to this Novax. See, no load anticoagulants are always better than warfarin, because of this. No need to monitor PTNR again and again for this patient. And if you use warfarin, and warfarin itself has so many side effects, okay, altered liver toxicity, all the side effects are there. So what we do is we always prefer no-load anticoagulants than warfarin, but exceptions are always there in medicine, and those becomes our questions. So exceptions, if you see, in any case of structural MS, meaning mitral stenosis, which is moderate to severe, okay, so that means even in mild mitral stenosis, you can give Novax. Only in moderate to severe mitral stenosis, you should never prefer Novax. Next, any prosthetic valves should never prefer Novax. Warfarin is the drug of choice. Or if the drug interactions are there with Novax, then you can go for warfarin. So 3 easy indications you should be remembering. And you should know that they are not preferred. Novax are always preferred only in severe MS and prosthetic valves. We don't have enough studies to support the use of Novax. Okay, it's not that no-load anticoagulants after usage is not effective. It's not like that. But there are very little number of studies have been done, and it's been going on. We feel that almost in the near future, warfarin will be completely replaced by this Novax. So it's very important to know all the Novax. Thrombin inhibitor, which is dabigatran, and factor 10A inhibitor, which is the rivaroxaban, as well as apixaban. Yeah. Next, rate control. How to control the rate? Easy. Just remember BCD. B for beta blocker, which is metoprolol. Mostly we use metoprolol only in atrial fibrillation. C for calcium channel blocker, verapamil or diltiazem. We can go for both, any of the one. Next, D for digoxin. So actually, rate control, how are you going to choose the rate control agents? See, the heart is smiling, no left ventricular systolic dysfunction is there. Heart is absolutely normal. In a structurally normal heart, you can go give beta blockers or calcium channel blockers. If you find the heart is failing, there is left ventricular systolic dysfunction, then you should only give digoxin. So if you see in this question, novel oral anticoagulants are used in treatment of moderate to severe MS? No, it is warfarin which is used. And patients with ischemic stroke due to AFib, anticoagulants should be used. Yeah, anticoagulants can be used after you rule out those critical conditions like massive stroke, more than two-thirds of MCA territory or half of PCA territory, that much big infarct, okay, or any bleeding risk or complications, or if the patient is having persistently high BP, like more than or equal to 185 by 110, then you can go only for this oral anticoagulants. Warfarin within 1 day of onset of stroke, and Novax within 2 days of onset of stroke. The Novax are contraindicated in prosthetic valve. Yes, they are contraindicated in prosthetic valves. And one more contraindication is severe MS. One more contraindication is any drug interactions. And all patients with atrial fibrillation who are candidates for cardiac surgery can be started on beta blockers. Yeah, they can be started on beta blockers because for candidates who are not candidates for cardiac surgery means uh, they don't have any LV systolic dysfunction. So they can be started on beta blockers or calcium channel blockers. They can be started. So if you see D, C, D is true. Okay. So today we have learned the basic core concept of when to use in stroke, how to use anticoagulant, when to choose how to use an anticoagulant. Okay, this is the most important algorithm I want people to remember this thing. Okay, this is the important concept now. Then know about this thing, Novak's contraindication. Okay, yeah. So I hope you learned something new today. Let's meet tomorrow with one more interesting question. Till then, thank you.
Okay, so good evening. We'll quickly start off with yesterday's question. Okay, so when coming to yesterday's question, okay, which one of the following statements is true about beta thalassemia trait? Okay, so I mean the question is about beta thalassemia trait. Okay, so it is associated with raised hemoglobin A2 level. Okay, it is associated with iron overload, it is associated with reticulocytosis, it is associated with splenomegaly. See, splenomegaly, reticulocytosis and iron overload are seen in Thal major. Okay, Thal major, but raised HbA2 level can also be seen in beta thalassemia trait. So this will be your answer. Okay. Which one of these statements is true about beta thalassemia major? Okay, now it is about major. The major cause of death in the contemporary era, that means after after starting the patient on iron chelators. Okay, so the major cause of death in contemporary era is liver failure. No, I told you the major cause of death, okay, in contemporary era is, that is without chelators, it is cardiac failure, and with chelators it is infection. Okay, then next, so this option is wrong. They've asked a true thing. A diagnosis of thalassemia major means iron chelation should begin immediately at the diagnosis. No, only after a particular number of transfusions, usually 10 to 12 units of transfused blood, we will begin chelation. So this option is also wrong. It is usually caused by deletion of 3 beta globin genes. This will hold good for alpha thalassemia. Beta thalassemia is point mutation. So this option is also wrong. Antenatal diagnosis and prevention are reducing. Yes, it is reducing the incidence by a prenatal next generation sequencing or and confirmation by chorionic villus sampling. So this will be your right answer. Okay, next. Today we will be dealing with sickle cell anemia. Okay, sickle cell anemia, it's a hemoglobinopathy, as you all know. There when we were dealing with thalassemia, it was imbalance between the chains. It was a reduced amount of normal chains. Here it is going to be abnormal chain synthesis. Okay, so there is abnormality in the amino acid sequence. Okay, at the end of today's session we should be able to answer this. So which one of these statements is true concerning sickle cell trait? Okay, so it is a theory based question. Then which one of the following is true concerning sickle cell anemia? So we should know the difference between sickle cell trait and sickle cell anemia. Okay, so when coming to sickle cell, just let us look into the concepts. Okay, here what is happening is glutamic acid is replaced by valine at 6th position of beta chain. This everyone knows. Okay, HbSS, that is homozygous form. Okay, HbSS, that is homozygous form, is the most common severe syndrome. Is the most common severe syndrome of this hemoglobinopathy. Okay, when HbS heterozygous, okay, double heterozygous, HbS with HbC combination or HbS with beta thal combination, okay, that time also there will be sickling, but the severity will be less. Okay, the severity will be less compared to HbSS. Okay, so what happens in this HbSS or HbS? What happens that when it is homozygous, I'll write it as HbS. Okay, what happens is this hemoglobin S can give up oxygen readily. It can give away oxygen easily. It can give, question this is, it can give away oxygen easily. Okay, so it will easily give away oxygen. So it will become, whenever there is less oxygen tension, what will happen is these hemoglobin hairs will become insoluble crystals. What will they form? Insoluble crystals. Okay, these insoluble crystals on further deoxygenation, okay, they will become polymerized. There will be many cycles of polymerization and depolymerization. and then permanently leading to formation of long fibers. Okay, permanently leading to formation of long fibers. They are nothing but 7 intertwined double strands with cross-linking. Excuse me. 7 intertwined long strands with cross-linking. Okay, so when these long strands are formed, these will cause membrane damage. These will cause membrane damage. Okay. Okay, so these will cause membrane damage. When they cause membrane damage, first thing is these become rigid. No, these become rigid and sickle shaped. So these are going to block the microcirculation. These are going to block the microcirculation, leading to infarct. Okay, leading to infarct. So this is the basic pathogenesis in sickle cell disease. So see here. So see here, actually what happens is, are you all able to see me? So here what happens is, see this oxygen, whenever this hemoglobin is in the normal, is having a normal structure, it is biconcave shape. Okay. So whenever there is a sufficient amount of oxygen, it is in the biconcave shape. Okay. So whenever there is depletion in oxygen, okay, and continued depletion of oxygen, what happens is sickle cells are formed. Continued depletion of oxygen, sickle cells are formed. Sorry for that inconvenience. See, whenever there is less amount of oxygen, okay, see, when there is sufficient amount of oxygen, the RBC shapes are normal. But whenever there is a reduced oxygen, what happens? Sickling occurs and polymerization occurs, and the shape of the RBCs become sickled. This is what I told you. This is the pathogenesis. So now after the pathogenesis, we will see what will happen. I am speaking about HBSS disease, okay, homozygous state. There's something called crisis. So what all can happen in this HBSS diseases? See, it can either be vaso-occlusive. It can either be vaso-occlusive or aplastic crisis or hemolytic crisis. Okay, under vaso-occlusive, we have painful crisis and sequestration crisis. Okay, visceral sequestration crisis. Fine. One more important point you have to know here, whenever there is co-inheritance with alpha-thal, okay, or whenever there is alpha-thal co-inheritance or raised HbF, whenever there is like persistent fetal hemoglobin, whenever such conditions are associated with HBSS, there will be a milder clinical course. Question, there will be a milder clinical course. So these are the crises. So the course of the disease when it is associated with alpha-thal or persistent HbF or raised HbF, what will happen? There will be a milder clinical course. That is why we give hydroxyurea to produce stress erythropoiesis, increasing HbF, which will lead to milder clinical course, isn't it? Fine. So when coming to the, we'll see just the symptoms in detail. Okay, we'll see the symptoms in detail. When coming to the symptoms, so vaso-occlusive, VO, okay, vaso-occlusive, in that we have painful. Okay, this is the most common type of crisis that you have to know, and it in your clinical scenario questions. Okay, most common type of crisis, and it is precipitated by acidosis, infection, dehydration, Okay, and deoxygenation. Deoxygenation in the sense any stress, surgery, high altitude, all these things. So all these things can precipitate the painful crisis. So what all can happen in this painful crisis? Avascular necrosis, bones. When coming to bones, it is very, very important. Okay, avascular necrosis. Okay, especially of the hip joint, and hand-foot syndrome. Hand-foot syndrome. So what happens in this hand-foot syndrome is there is painful dactylitis. Okay, there is painful dactylitis. So the small bones are affected. There is necrosis of the bone, and further leading to shortening of the phalanx, leading to varying sizes of the fingers. Okay, so this is hand-foot syndrome. Avascular necrosis and hand-foot syndrome. So the treatment for this disease, for this crisis is analgesia. It can be prevented by exchange transfusion. I mean, during the crisis, exchange transfusion. It can be prevented by adequate oxygenation. Adequate oxygenation. Okay. So next thing is spleen. When coming to, okay, this is the thing. This is the avascular necrosis. If you observe, this is the avascular necrosis of the bone. Okay, so if they give you some history suggestive of HBS and give you this image, it is avascular necrosis. It is painful crisis. Okay, this is dactylitis. If you observe, when you take an X-ray, this is dactylitis. When you observe, when you take an X-ray, see this middle finger, it is shortened. Middle finger is usually longer, isn't it? So it is shortened here. So this is also an important image-based question, right? So apart from this, what all can happen? What other things can happen? Painful crisis, most common, we saw that. Splenic sequestration can occur. So especially in infants, okay, in infants, there will be an enlarging spleen. There will be sudden drop in HB. Okay, that is when we have to suspect this. So in infants, there will be an enlarged spleen in case of HBSS. Okay, then next we have aplastic crisis. When will the patient go into aplastic crisis? The patient will go into aplastic crisis when the kid has parvovirus infection, parvovirus B19 infection, or when the patient has folate deficiency. Right? After this, the other organs which are affected, we have to know. The other organs which are affected, especially brain and spinal cord stroke. Brain and spinal cord stroke. Okay. Pulmonary hypertension. Question, these are all of the following can be seen in sickle cell disease except, okay, pulmonary hypertension. Fine. Autosplenectomy in adults. See, in HBSS, usually within 5 years, autosplenectomy will occur. Okay, when it is inherited with other like double heterozygous with HBC or beta thal or alpha thal, it is little later. It is more than 5 years of age. Okay, and then the patient can go into chronic renal failure, progressive retinopathy. Okay, the screening test is sickling test with dithionate or disodium phosphate. Okay, but this is the screening test. So what is the investigation of choice? It is HPLC, high performance liquid chromatography, or HB electrophoresis, where HbA will be reduced and HbF will be, HbS will be increased. Okay, amongst the, before that, I'll just show you the, so see, these are the silent strokes, infarcts, okay, silent infarcts, which are seen in CT. Okay, so serial CT we have to do and see, and we can predict stroke early. We can predict early and we can prevent by giving exchange transfusion. Very important point. We can do serial CT, okay, at particular intervals, and we can predict stroke and can be prevented by giving exchange transfusion. Okay, see, these are the leg ulcers, okay, which are common in HB SS due to occlusion of the major vessels. Okay. So this is the peripheral smear. If you observe here, are you able to see these cells? These are the sickle cells. These are the sickle cells. Fine. Okay. This is during crisis. Otherwise, it is going to be like this, showing only tactoid forms. These are all tactoid forms. Fine. That means they're just folded, holly leaf like or tactoid forms. That means they're just folded like this. They'll be folded. Okay. Sickle cells are these. They're proper sickle cells. Fine. And one more important point I want to tell you when coming to this one, novel therapy, because in every disease they're asking novel therapy. I'm just adding a point on this. Novel therapy is crinzalizumab. It's not actually novel. Now we are using it. It is no more novel. Okay. Crinzalizumab. This is antibodies against P-selectin. So this prevents the adhesion of RBCs to the endothelium and prevent occlusive crisis. Okay, crinzalizumab. Otherwise, exchange transfusions, maintaining oxygenation, hydroxyurea, all those old drugs, you have to remember crinzalizumab. Okay, so now we will quickly solve the questions. Okay, which one of these statements is true concerning sickle cell trait? Sickle cell trait may cause mild anemia. I'm speaking about trait. Okay, may cause mild anemia. This we have a doubt. We'll just leave it like that. Sickle cell trait protects against severe malaria in endemic regions. Yes, this is a point. You all know. So this is true. Sickle cell trait occurs mainly in females. No, I never told any sex prediction, isn't it? So males is equal to females. Sickle cells can be usually observed in the peripheral smear. No, in trait you cannot observe sickle cells in the peripheral smear. Only during crisis, when there is deoxygenation or stress, when the patient gets into crisis, only you can see. Otherwise, it is a normal smear. And here coming to anemia also, in sickle cell trait, almost the HB levels will be near normal. So you will not see anemia. Fine. So the answer is sickle cell trait protects against severe malaria in endemic regions. Again, if this was sickle cell disease, yes, anemia will be present and sickle cells can be found in the peripheral smear. Which one of this is true about sickle cell anemia? The oxygen dissociation curve is shifted to the left. That is, hemoglobin gives up oxygen less easily than normal. Did I tell you that? No, I told you hemoglobin is given away very easily by HbS, isn't it? HbSS will give away hemoglobin very easily, and that itself will aggravate sickling, isn't it? So the oxygen dissociation curve is shifted to right. So this option is wrong. It is associated with stunted growth. It might be associated, but it is not a prominent feature like thalassemia. So this option is wrong. It may cause ankle ulcers despite preserved flow in large arteries. No, whenever the flow is, there is obstruction in the flow, only then there will be ankle ulcers. So, sorry. So whenever the flow is obstructed, yes, there will be ankle ulcers. So this option is right. Fine. So when the ankle ulcers is one of the most common manifestation in other organs other than the painful crisis. Okay, the occurrence of stroke associated with sickle cell disease is not predictable. I told you it can be predicted by serial CT scans, and we can prevent it by giving exchange transfusion. So this is wrong. This option is wrong. Fine. So the option here is, what is option? It may cause ankle ulcers despite preserved flow in the large arteries. Okay, so small arteries can undergo occlusion and lead to ankle ulcers. Fine. So this is the right answer. Okay. So this brings us to the end of today's class. Okay, thank you.
Good evening. We'll start with one of the important topic in microbiology, that is your Salmonella and non-typhoidal Salmonella. So as we know, why Salmonella is so famous. The typhoid fever is so famous in India because it's considered to be one of the endemic diseases in Indian population. Okay, so we have two types of Salmonella. Okay, so we have typhoidal and non-typhoidal Salmonella. So typhoidal Salmonella, you have Salmonella Okay, so we have typhoidal Salmonella and non-typhoidal Salmonella. So in typhoidal Salmonella, we have Salmonella typhi and Salmonella paratyphi, which have A, B, C. So always genus we write in a capital, species we write in a small letter. But here we are writing in capital letter because it's not the species. Okay, I hope I'm visible now. And so we'll continue with classification of Salmonella. So we have Salmonella typhi, we have paratyphi, A, B, C. So this typhi and paratyphi A, B, C, which causes enteric fever. Okay, so enteric fever or typhoid fever we used as a synonymous. Both is caused by Salmonella typhi and paratyphi A, B, C. Now coming to non-typhoidal Salmonella. Non-typhoidal Salmonella, which is responsible for gastroenteritis and septicemia. Okay, so this is responsible for enteric fever. This is responsible for gastroenteritis and septicemia. Now, this is gram negative, right? We have discussed the classification of Enterobacteriaceae. So this is one of the member of Enterobacteriaceae. see, they are gram-negative rod. Okay, and they are motile. They are motile organism by peritrichous flagella. So you can see this picture. They have peritrichous flagella. They are motile by peritrichous flagella. One of them is non-motile, that is Salmonella gallinarum, which is non-motile species. Right? So it has been asked previously, MCQs, that is, which is non-motile species of Salmonella? Salmonella gallinarum is a non-motile Salmonella. They are aerobes and facultative anaerobes. They forms, this is McConkey agar, they forms non-lactose fermenter colony. Okay, and this is deoxycholate citrate agar. Okay, DCA, deoxycholate citrate agar. This is a selective media for Salmonella. You can see black color colony because they produces hydrogen sulfide. And this is xylose lysine deoxycholate agar, XLD, which we say, that also black red colony with black dot because of hydrogen sulfide production we see. Okay, now they have O antigen, okay, which is flagellar, sorry, H antigen, which is flagellar, O antigen, which is somatic, and VI, which is capsular antigen. So they have three antigen: flagellar, somatic, and capsular antigen, which is responsible for virulence of the Salmonella. So H antigen, which is flagellar, protein in nature, which is highly antigenic. O somatic, which is polysaccharide, low antigenic. Capsular, which is poorly antigenic and polysaccharide in nature. Later, antibody against H antigen appear earliest and persists longest. O antigen appears later and disappears in a week. This VI antibody indicates poor prognosis. So H is flagellar, O is somatic, VI is capsular antigen. Okay. And among this, H antigen is the highly antigenic. Now, what are the variation we see? Okay, so variation is O, H, and VI antigen we have. So smooth to rough variation, which is called SR variation. Okay, and because of that, auto agglutinability you see in Salmonella. They have lysogenic aversion, which we have seen in genetics when we were discussing with the help of bacteriophages. Then OHO, because of loss of flagella happens. Then phase variation we have. Then VW variations can be seen in the Salmonella. Now, which is the classification, antigenic classification, which we use in Salmonella? That is Kaufman-White classification is the classification which we use in the Salmonella. Okay, so on the basis of O antigen, on the basis of phase 1 of H antigen, phase 2 of H antigen, we see this classification. So you just remember, your Salmonella paratyphi belongs to O antigen group and sero group will be A. Paratyphi B will be 4 or B. Paratyphi C will be 7 or C1. Paratyphi D will be, typhi will be D or 9. So paratyphi 2, B will be 4, C will be 7, and typhi will be 9. Okay. So what is the infective dose of this bacilli? First, how it comes inside the body? Through fecal-oral contamination of food and water. What is the infective dose? Very important. Infective dose of this organism is 10 to the power 3 to 10 to the power 6 bacilli. Yesterday we discussed Shigella. What was the infective dose there? 10 to 100 bacilli. Here infective dose is little higher, 10 to the power 3 to 10 to the power 6 bacilli. And people who have decreased stomach acidity, recent history of surgery, those are prone for Salmonella infection. Humans are the only host of typhoid fever. Please remember, this has been asked previously, and this is a probable question. Who is the host of Salmonella infection? Salmonella typhi or typhoid infection or enteric infection is human is the only host. Okay. What is the incubation period? 10 to 14 days. That is also previously asked. as we know, food and water, so poor sanitation, cleaning and all. So these diseases are more common in developing country than your developed country. What type of carrier we see? It can be fecal, okay, present in the gallbladder, excreted in a stool, so those are fecal carrier. Urinary carrier, multiply in the kidney and excreted in the urine, so that is urinary carrier. Now this depending on the organ, now depending on the carrier, it can be convalescent when we say 3 weeks to 3 months after infection. It carries, so this is your convalescent carrier, which has 3 months to up to 1 year is your temporary carrier. Chronic, which carries this bacilli more than 1 year, those are chronic carrier. Okay, so typhoid Mary, which was the source of outbreak of salmonella in one of the restaurant in abroad, so she was the carrier of typhoid. Okay, typhoid bacilli, that is Salmonella typhi. So what specimen you will culture, what specimen you will take for diagnosis of Salmonella? So please remember mnemonic BASU, BASU. Okay, so first week most ideal specimen is your blood. Second week you will do antibody detection, that is your Vidal test. Third week is your stool, and fourth week is your urine. So we say BASU. Okay. So we have first week blood culture, clot culture, bone marrow aspirate, duodenal aspirate, these all will be positive. Second and third week, you can do Vidal or stool and urine culture. Fourth week, stool and urine. Carrier, you have to detect VI antigen and stool and urine. As we have discussed, urinary carrier and fecal carrier. Now we discussed about these culture media. We'll start with enrichment broth. As we know, enrichment means liquid media, right? So it has been asked, which is the enrichment media for Salmonella? Please remember selenite F broth. Various time in various exam, your NEET, your AIMS, your PGI, it has been asked selenite F broth is enrichment broth for your Salmonella and Shigella. Apart from tetrathionate, gram-negative broth. What is a selective media? This we have discussed, DCA, XLD, and Wilson-Blair media. They are catalase positive. All Enterobacteriaceae are catalase positive, oxidase negative. So this will also follow the same rule, right? It reduces nitrate to nitrite. Indole is negative. They are citrate positive except Salmonella typhi and Paratyphi A, which are citrate negative. Typhi and Paratyphi A. They produces H2S. You can see this black precipitate is because of hydrogen sulfides production. Okay, so Salmonella typhi produces little of H2S, which we say speck of H2S. Paratyphi B will produce, so this is your typhi, okay, and this is your Paratyphi B, which produces abundant of H2S. Paratyphi A does not produce, it's absent. Now Vidal test. Vidal test is your agglutination, okay, antibody detection test, tube agglutination test, which we do in second week. So you are using O antigen of Salmonella typhi, H antigen of typhi, Paratyphi A and B. Why we don't use all typhi, Paratyphi A and Paratyphi B H antigen? Because they all cross react because of sharing of factor 12. So we use only one O and 3 H antigen. Okay. And if TO and TH is raised is because of Salmonella typhi infection. If TO and AH is raised is Paratyphi A. TO BH is raised, Paratyphi B. Only TO is raised is because of reinfection, recent infection, okay, past recent infection or either of the type, okay. Only TH is raised, it may be because of anamnestic reaction, which can happen because of unrelated fever like malaria, other fever, you get anamnestic reaction, or because of convulsant stage of the disease. When all three are raised is because of vaccination. Patient might have taken TAB vaccine. Okay. What is significant titer? 1:80 is considered to be titer. Okay, significant titer for Salmonella. If the titer is above that, we give it as a patient might be positive for typhoid infection. Okay. So what is anamnestic? As we discussed, malaria, dengue, unrelated fever can give anamnestic reaction. So we have 3 vaccines: TAB, VI polysaccharide, and Typhi oral vaccine. TAB is because of heat kit wholesale vaccine of Typhi, Paratyphi A and B, all 3 are there. Then polysaccharide vaccine, which we have VI polysaccharide of Salmonella typhi 2, which is single dose IM or subcutaneous is given. Typhi oral is because in this mutant strain of Salmonella typhi, which is that mutant strain which lacks UDP galactose 4 epimerase enzyme. Those mutants are used, and it is self-destructive after 4 to 5 divisions. And more than 6-year age group we give, and it is given orally before food. So what is the treatment of choice? We will give accord drugs. Okay, ampicillin, chloramphenicol, cotrimoxazole, tetracycline is the accord drugs which we recommend for Salmonella. Apart from that, we recommend fluoroquinolone, which is ciprofloxacin, and ceftriaxone, that is 3rd generation cephalosporin, apart from accord, cipro, and ceftriaxone. Okay, or azithromycin. These 3 drugs, apart from accord, we recommend for Salmonella infection. What is MDR Salmonella? Multi-drug resistant Salmonella, which shows resistant to chloramphenicol, which shows resistant to ampicillin, which shows resistant to cotrimoxazole. All 3 is multi-drug resistant Salmonella typhi. What is nalidixic acid resistant? Which is shows resistant to ciprofloxacin. If nalidixic acid is resistant, it means it will be resistant to ciprofloxacin. Okay, non-typhoidal Salmonella, you have example, please remember, typhimurium, enteritis, Newport, cholera suis are different example for non-typhoidal Salmonella. So you will be given options out of these, which is non-typhoidal Salmonella: Typhi, Paratyphi A, Paratyphi B, or Typhimurium or cholera suis. So these cholera suis or Typhimurium is your non-typhoidal Salmonella. Okay, this has animal reservoir, but typhoidal Salmonella is only human pathogen. Okay, is food product is poultry, dairy product. This is mainly waterborne. Okay, so gastroenteritis and bacteria. So now coming to Hemophilus, which is gram-negative Coccobacilli, and factor X and factor V, that is X is hemine, V is NAD, is needed for the growth of Hemophilus influenzae. It has polysaccharide capsule, and type V is the most virulent, and this is oxidase positive. Okay, and it needs carbon dioxide for their growth. Causes, they are present as in upper respiratory tract, and transmission happens by respiratory droplet. Okay, type B is important human pathogen. Coming to Hemophilus ducreae, which causes chancroid, which is one species of Hemophilus, which is ducreae, which causes chancroid, which is sexually transmitted disease. Okay. Then you have normal flora, parainfluenza, Aprophilus aegypti, Aprophilus, okay, parainfluenza, these causes pneumonia and endocarditis, aegypti, which causes purulent conjunctivitis. Okay, so you need X and V factor, you need CO2, okay, for the growth of Salmonella, Hemophilus. Factor X or 10, we say it is a hemine factor. Factor V or 5, we say anidine, nicotinamide adenine dinucleotide. Okay, so in gram stain, it gives school of fish or railroad appearance. You can see the gram stain. This is your Hemophilus influenzae. They give one of the properties, satellitism. So if you streak Staph aureus, beta hemolytic Staph aureus on the blood agar and Hemophilus influenzae perpendicular, so which Hemophilus influenzae is near to Staph aureus, those will be larger in size, and when it goes away, the size will decrease, because Staph aureus gives factor 5. Okay, that is NAD factor, and your blood agar or chocolate agar plate will give factor X. Apart from that, it has Fields agar and Leventhal agar, chocolate agar as a culture media of Hemophilus. So it causes, type V causes meningitis, otitis media, sinusitis, epiglottitis, and meningitis is by type B. Other bacteremia and pneumonia is non-typeable. Okay. We have a vaccine, which is HIV vaccine. And what is the treatment? Ceftriaxone is the treatment for Haemophilus influenzae. Okay, rifampicin is chemoprophylaxis. So this has been asked previously. What is the chemoprophylactic drug for Haemophilus? Is rifampicin. Household contacts, family members can be given rifampicin as a chemoprophylaxis. Haemophilus epilepti, which is called Brazilian purpuric fever. Please remember, this has been asked previously. Brazilian purpuric fever is caused by Haemophilus epilepti. So Ducrey we discussed, it causes soft chancre. Okay, and there will be local lymph node, regional lymph node enlargement, which present as a bubo. Please remember, bubo is seen in Haemophilus Ducrey infection, that is centroid or soft chancre. What is HASEC? Please remember the full form of HASEC. H for Haemophilus parainfluenzae, Aprophilus or Paraaprophilus. Then A for Actinobacillus, Actinomycetum comitans. C for Cardiobacterium hominis. E for Echinella corrodens. K for Kingella kingae. So it has been asked which of them is not a component of HASEC group. So out of these, you can just remember parainfluenza, Aprophilus, Paraaprophilus, Actinobacillus, Actinomycetum comitans, Cardiobacterium hominis, Echinella corrodens, Kingella kingae. These are the member of HASEC family, okay, HASEC group. And they are responsible for endocarditis, which is the drug of choice is ceftriaxone, except Echinella, where ampicillin is the drug of choice. Okay. So these are the important topics which we discussed today. Again, tomorrow we'll meet with some important topic. Thank you.
Okay, well, start பண்ணலாமா? Shall we start? Yeah, okay. Yes, hello. Welcome back to another important topic with respect to forensic medicine for the upcoming INICET. So today's topic is about incised wounds and its relevance with respect to INICET MCQ. Okay, so the first slide, please. So in the first slide, you could see the incised wounds, right? So incised wounds would have 3 dimensions, so length, breadth, and depth, right? So it is a 3-dimensional injury. So length, breadth, and depth. Okay. Now length will be of the greatest dimension with respect to incised wound. So please remember, incised wound will have length, breadth, and depth. Of the 3, greatest dimension is length, right? Greatest dimension is length. So just remember, with respect to stab wound, greatest dimension is depth, right? So greatest dimension is depth with respect to stab wound, whereas greatest dimension is length with respect to incised wound. So incised wound is nothing but cutting, right? Cutting a skin. So look at the image, you could see the margins of the wound are regular. Regular means a straight line. See, it can be of any shape, right? The wound can be of any shape, it doesn't matter, but the margin should be, right? Then margin must be clean margin. So what is it? Clean margin, which simply means margin will be free from aberration or contusion. So margins of incised wounds will not have, I repeat, will not have aberration or contusion. So margin will be irregular, that is straight or regular. Margins will be clean, free from aberration or contusion. The last line, the margin is clean, is so important, right? I'll at the end, after completing this incised wound, I'll correlate the margin with one another wound, right? One of the repeat MCQ, right? So we'll go to the next slide, next photograph. Yes, next slide, please. So incised wounds would have two parts, right? This, for convenience sake, for reading or for academic sake, we divide the incised wound into two parts. Yes, next slide, please. So it is head end and tail end, right? The wound is divided into head end of the wound and tail end of the wound. Next slide, please. Yes, you see, I have indicated in the red arrow, a big portion. So out of the whole incised wound, one portion is bigger and other portion is small. So the red line indicates bigger wound portion, right? Bigger to begin with, big portion. It is head end. Head is big, right? Head is big. Then the yellow portion indicates tail end, which means tailing means wound becomes superficial, right? Wound becomes superficial and shallow, right? Shallow. So wound will be deeper or big in its initial part, that is head part, head end. Whereas when the wound becomes superficial, it is called tail end, or the phenomena is called tailing, right? Phenomena is called tailing. So please remember, tailing is associated with incised wounds. See, tailing is associated with option A, incised wounds. That is the more appropriate answer. If incised wound is not there, then go for stab wound. I'll tell you again. Tailing is a phenomena where incised wound becomes superficial while withdrawing the weapon. While withdrawing the weapon, the wound becomes superficial. This is called tailing. So tailing is mostly associated with incised wounds. If the option incised wound is not there, go for stab wounds. Right. So what is the use of tailing? So tailing indicates direction of force, right? Direction of force or direction of injury. Right? That is the medico-legal significance of tailing. So tailing indicates direction of force or direction of weapon or direction of injury. Right? All are same. Right? So we'll go to third slide. Yes. The next slide, please. Yes. So another important point we should know about incised wound is trial wound. See, trial wound is one of the most liked MCQ for PGI, right? Most liked question for PGI is trial wound. See, trial wound is otherwise called as hesitation wound, right? Or self-inflicted wound. Self-inflicted wound or hesitation wound or trial wound or simply trial cuts, right? Trial cut or trial wound. So incised wound is always called as cut wound, so don't worry. Or slash wound, slash, making a slash, right? Yes. So what is trial wound? Trial wound is making multiple superficial cuts. Trial wound is making multiple superficial cuts before making a deeper cut, right? Making multiple superficial cuts and then making a deeper cut is called trial cuts or trial wounds. So what it means trial wounds? So trial wounds, like I told you, from tailing you can find direction of force or direction of injury. Okay. Another important point with respect to trial wound. See, the question will go like this: which of the following are characteristics of a trial wound? See, being an incised wound, trial wounds will have regular margin. Trial wounds will be free from aberration or contusion, right? With the help of tailing, you can find direction of force, right? So all are understood. Now, what is this last line? Artery involvement. So please remember, pay attention and please remember, incised wounds or trial wounds of wrist, trial wounds of wrist would usually escape radial artery. So trial wounds of the wrist would usually escape radial artery. And likewise, trial cuts of neck usually escapes carotid artery. So radial artery and carotid artery usually escapes trial cuts of self-infliction, or self-inflicted trial wounds would rarely cut radial artery and rarely cut carotid artery. So never forget this point, right? Never forget this point. This is one of the important point to differentiate trial cut from a homicidal cut, that is cut by other person or by assault cut. In homicidal cuts, artery involvement will be present. Carotid artery or radial artery might get involved, right, in homicidal cuts. So trial cuts would never involve radial artery. Trial cuts would never cut carotid artery, right? Okay. So another repeat MCQ with respect to incised wound is, how do you differentiate incised wound from another injury called split laceration? See, this is n number of times, n number of repeats with respect to forensic medicine as a whole is, how do you differentiate incised wound from a lacerated wound, right? Particularly split laceration. So incised wound, like I told you, you could remember the previous points: regular margin, clean margin, right? Yes, caused by sharp edged weapon, okay, right? So we can find the tailing, yes, of course, right? So another important point is, you see the tissue bridge. So tissue bridge means vessels, nerves, soft tissue fibers from one margin of the wound to other margin of the wound will be intact at the base of the wound. So if you look at the base of the wound, even the wound in the forehead, see, just above the eyebrow, if you take a close look at the wound has connecting bridges or tissue bridges. A few soft tissues run from one margin to the next margin. This is tissue bridge. This tissue bridge is typical of split laceration, right? This tissue bridge is typical of split laceration. Incised wounds would never have tissue bridge. Please remember, incised wounds would never have tissue bridge because all tissues will be clean cut. So there won't be any intermediary or uncut fibers with respect to incised wounds. You can easily remember in the next photo. I've shown you a photo. You see, this is a pizza, right? Pizza. If you take a slice of pizza, it is split laceration because the cheese will be between one piece to another piece. The cheese will be connecting, right? Taking a pizza portion would have the cheese connected from one piece to another piece. This is split laceration. Whereas if you use the knife, you could see in the shops they used to cut the portions of pizza and give it to us, right? If you cut, the cheese will not be present between two adjacent pieces. So this is incised wound, clean cutting incised wound, and the tissue bridges is split laceration. So you can easily remember this using this pizza example, right? Pizza example. So next we'll go to, yes, next slide we'll go to. Next slide, please. So next slide is list of one-liners. Yes, one-liners. So now I've jumped to the slides. Previous slide, please. I've jumped 2 slides. Previous one, please. Incised, yes, thank you. Incised wounds, one-liners. Yes. See, in the last presentation, I've told you certain one-liners with respect to stab wounds. So now I'll tell you certain repeat one-liners in INICET with respect to incised wounds. See, often repeated MCQs, hesitation cuts or trial cuts or suicidal in nature on accessible parts of body. Accessible parts or exposed to parts, right? Exposed to parts or accessible parts of the body. Suicidal on accessible parts, right? Incised wounds on genital. See, please remember, incised wounds on genital are homicidal in nature unless proved otherwise. Incised wounds on genital is homicidal. So have no doubt, incised wounds on genital, homicidal. Okay. Now I'll tell you an extra point. Now, incised wounds on genital can be self-inflicted if a person is suffering from schizophrenia-like illness, right? So, incised wounds on genital are always homicidal until proved otherwise, except if an individual is having psychiatric illness, it could be self-inflicted. So, except in mental illness, incised wounds on genital are always homicidal, right? Always homicidal. And incised wounds on back are almost homicidal, right? Almost homicidal, right? Yes. So next we'll go to cause of death, right? Cause of death. See, if you cut a vessel, clean cut a vessel, there will be bleeding, right? No doubt in it, bleeding. Hemorrhagic shock is likely. So apart from it, if the cut is in the throat, there is possibility for air embolism or drowning by blood. See, look at this option, drowning by blood. The drowning by blood was asked once in the AIMS, which is nothing but blood enters the trachea. So you cut the throat, you cut the vessel as well as the trachea. From the cut vessel, blood enters the trachea. If trachea is filled with blood, blood is nothing but fluid. So fluid replacing air in the respiratory tract is called drowning. Right? Drowning is replacement of air by liquid. That is air by water. If air is replaced by blood or blood fills the trachea, it is called drowning by blood, right? Drowning by blood. And rarely you see there is an option called choking, right? Choking. See, answer for that MCQ is choking. Choking is not a cause of death in cutthroat injury. Choking is mechanical obstruction, right? Mechanical obstruction of trachea. Mechanical obstruction of trachea is not possible with cutthroat injury. The original MCQ is not a cause of death in cutthroat injury, and the answer is choking, right? Answer is choking. So air embolism is possible, hemorrhagic shock is possible, drowning by blood is possible, right? Yes, only the first three are possible, right? So next is another image-based MCQ. Now this image-based MCQ is nothing but varied size of incised wounds or stab wounds, right? It is a combination of stab wound and incised wound of varying dimension, right? Varying dimension. In other words, just take the word pleomorphism. Pleo means varied, right? Pleo means multiple or varied. Morphism is morphology. Morphism is morphology, which means there will be difference in the dimension. Morphology is nothing but dimension, right? Dimension of the incised wound and stab wounds in a body will be different. So different dimension of injuries in the body. Yes. So what is the take here? The take here is all the wounds would be caused by the same weapon. Same weapon. A single weapon or a same weapon producing injuries of varied dimension. Right? It could be incised or stabbed. So varied dimension injuries by the same weapon is called pleomorphism, right? Another image-based question, pleomorphism, right? So next slide, please. So next slide is a wound which is called chop wound, right? Chop wound. See, you have to read chop wound side by side with incised wound, right? I'll tell you the reason. See, chop wound technically has two components, sharp force component as well as the blunt force component. So chop wound is a kind of sharp force wound that has got blunt force component also. So chop wound is basically a sharp force wound that has got blunt force component additionally, right? So what are the next two lines? So regular margin, that is margin will be straight, regular margin, but margins have aberration or contusion. Margins have aberration or contusion. See, this is what I told you in the first slide itself. With respect to margin, a repeat MCQ is there and it confuses you most of the times. So please be crystal clear. So please pay attention. Margins are regular, margins are clean, incised wounds. Margins are regular, margins are clean, incised wounds. Margins are regular, margins have aberration or contusion, chop wounds, right? Chop wounds, right? Chop wounds. So margin is irregular, it is altogether different. Irregular margin, laceration, no doubt in it, right? Easy to remember. Irregular margin, laceration. If it is regular margin, Margin is clean, incised wound. Margin have contusion or abrasion, chop wound, right? And another repeat MCQ in chop wound is if you raise a weapon like an axe. Axe is a typical example to produce chop wound. And if you try to chop a man, heel of the weapon strikes the victim first. Heel end of the weapon strikes the victim first, right? Heel end of the weapon, right? So next slide, please. Yes, next slide. So another important point you should remember with respect to the sharp force wounds or homicidal wounds in general is defense wounds. See, defense wounds are nothing but a person tries to defend himself, right? Defend himself. See, I told you defense wound can be present in any kind of wounds. It could be a blunt force wound, it could be a sharp force wound. It is just a reaction to an attack, a homicidal attack. Defense wound indicates homicidal attack, right? Defense wound indicates homicidal attack. Defense wound is nothing but instinctive response by a person to an attack. So if a person attacks us, what we do instinctively, so we try to defend ourselves, right? So this is passive defense. So passive defense is on the ulna aspect. So ulna will be hit by a passive defense. You're just protecting yourself, right? Passive defense. Ulna or extreme fingertips. This is how we protect, right? So ulna or extreme fingertips. Then what is active defense? Active defense is you're trying to take the weapon. You're trying to seize the weapon, right? So active defense wounds will be on the web spaces, right? So defense wounds could be blunt force wounds or sharp force wounds, right? No doubt in it. So most often defense wounds would be sharp force wounds. Mostly defense wounds would be sharp force wounds because in blunt force wounds, active defense would be difficult to identify. Right? So active defense wounds in particular is mostly seen with sharp force wound homicidal attack, right? Sharp forced homicidal attack. So defense wound indicates homicidal attack. It is an instinct body protecting mechanism, right? Okay. So it could be active, you're trying to seize the weapon, or it could be passive, fingertips and ulnar border. Then the next type is offensive manual wounds. Offensive manual wounds. See, it is nothing but if the victim is trying to hit the assailant. See, just understand the difference between defense wound and manual wounds. Defense wound is defending, protecting ourselves, whereas offensive manual is hitting the assailant. See, both the defense wounds as well as offensive manual wounds will be present in the victim. Right? So defense wound will be present in the victim. Offensive manual wounds will be present in the victim. Right? No doubt in it. Offensive wound will be due to hitting the assailant. Right? A man is trying to cut us with a knife or sickle. So what we do? We try to protect ourselves. Yes. Or if possible, we try to punch him. Right? So this is offensive manual. Right? Offensive manual is trying to hit the assailant. So offensive manual wounds will be present in the knuckles, right? Knuckles. So that was the question there in the aims. Offensive manual wounds will be present in which part of the body, right? Which part of the body? Knuckles, right? Knuckles, right? Yes. So you'll see one more offensive manual wound is there. Yes. So this brings into our presentation today. So we'll meet with another interesting topic likely for INICET question tomorrow. Thank you.
So, good evening. Today we'll start another important topic. We'll discuss about the cornea, the anatomy of the cornea and the important instruments we have in cornea. Okay. So, coming to the histology of the cornea, we know the cornea has 6 layers. the superficial epithelium, which is stratified squamous non-keratinized epithelium. We have the Bowman's layer. We have the substantia propria. We have the Dua's layer. The Dua's layer is the recently discovered layer by Dr. Harminder Dua. So the Dua's layer lies between the substantia propria, the stroma, and the Descemet's membrane. So it is the strongest layer of the cornea. So they may ask you which is the strongest layer of the cornea. The Dua's layer is the strongest layer of the cornea. Then we have the Descemet's membrane. Last is the endothelium. See, one important thing you'll have to remember in the corneal endothelium is the sodium potassium ATPase pump. The sodium potassium ATPase pump is the one which is responsible for maintaining the corneal transparency. Okay, so the corneal transparency is maintained by the corneal endothelium via the sodium potassium ATPase pump. Next important point we have to discuss is the various factors which help in determining the transparency of the cornea. Okay, so first is the peculiar arrangement of the corneal lamellae. So according to the Morris theory, the corneal lamellae, the epithelial cells of the corneal lamellae are arranged in a regular pattern. Okay, the regular pattern of arrangement of the corneal lamellae is the main factor responsible for the corneal transparency. Next is the avascularity of the cornea. We know that the cornea is avascular. It receives its nutrition from the aqueous and the air. The avascularity is another important factor responsible for the corneal transparency. The relative state of dehydration. Here we have to remember the sodium potassium ATPase pump present in the endothelium, which is responsible for the dehydrated state of the cornea. Next is the metabolism of the cornea. It is a highly active metabolism which happens in the cornea. And last point to remember is the difference in the refractive index of the air and the cornea. So the refractive index of air is 1, cornea is about 1.33. So this difference is responsible for maintaining the transparency. So they may also ask, where is the maximum refraction occurring in the eye? Okay, so remember the air cornea interface. The air cornea interface is the site of maximum refraction in the eye. So these are the important factors which are responsible for maintaining the corneal transparency. So this is the stromal transparency theory of Morris, which was described in 1957. So the transparency of the stroma is due to the regular lattice arrangement of the collagen fibrils. This lattice arrangement of the collagen fibrils, because they are regularly arranged, the backscatter of light is completely suppressed, or the backscatter of light is completely absent due to destructive interference. The backscatter of light is completely suppressed. It is suppressed due to destructive interference. Okay, so this is the stromal transparency theory of Morris. Okay, so next we discussed about the important instruments in ophthalmology. So the first of the corneal instruments important in cornea is the pachymetry. What is the pachymeter used for? The pachymeter is used to measure the corneal thickness. So what is the use of measuring the corneal thickness? So we know that after doing an applanation tonometer, high false positive rates are seen in a thicker cornea and high false negative rates are seen in a thinner cornea. So after measuring the IOP with the applanation tonometer, it has to be corrected for the corneal thickness. So this instrument, the pachymeter, is one which is responsible for the checking the corneal thickness. The central corneal thickness is measured by the pachymeter. The next is what is this instrument? This is the Cockett and Bonnet. Sorry, this is the handheld Cockett and Bonnet aesthesiometer. So what is the aesthesiometer used for? The aesthesiometer is used to measure the corneal sensation. So the corneal sensation is measured using the aesthesiometer. So it consists of a monofilament nylon. Okay, it consists of a monofilament nylon, the length of which can be adjusted by rotating the knob. Okay, it consists of a monofilament nylon, the length of which can be adjusted by rotating the knob. So smaller the length, okay, so smaller the length of the filament, more is the pressure which is appeared. So more will be the pressure on the cornea. Okay, so smaller the length of the nylon filament, more is the pressure put on the cornea. So this is directly proportional. Okay, so the Cockett and Bonnet aesthesiometer is the gold standard for measuring the corneal sensation. So this can be a potential question in your INICET. Okay, so this is, instead of a cotton whisk, we have a nylon monofilament. Okay, similar to your fishing line. So it is used to stimulate the cornea. The stiffness of the filament is controlled by changing the length of the filament using the slider. Okay, so as the length decreases, the pressure increases from, the value is 11 millimeter per gram to 200 millimeter per gram. Okay, so 11 millimeter per gram to 200 millimeter of gram is the pressure which has to be applied over the cornea. This is the Cockett and Bonnet aesthesiometer. Okay, so next instrument is the specular microscope. What is the specular microscope used for? So this is how the instrument appears, the specular microscope. This is the reading of the specular microscope. So the specular microscope is used to study the corneal endothelial. Specular microscope is used to study the corneal endothelium. Okay, specifically the corneal endothelial count. So if it indicates this total cell count is less than 2000, if the total cell count is less than 2000, it indicates a high chances of the corneal endothelial decompensation. It indicates a high chances of corneal endothelial decompensation. Okay, the specular microscope, apart from the cell count, it also shows the arrangement of the cells, also shows presence of polymechanism. Also, it also helps to identify the dystrophies. Okay, so this is the normal healthy arrangement of the polygonal cells. Here you see the pleomorphism, that is the change in the size of the various cells. Then we have the polymegathism, that is what happens, the endothelial cells do not have a regenerative capacity. The endothelial cells, once they are damaged, the remaining cells, what happens to the remaining cells? The remaining cells increase in size, which is known as polymegathism. Okay, so the endothelial cells do not have the capacity to multiply, so the remaining endothelial cells will increase in size in order to compensate for the function. This is known as polymegathism. The last slide is the corneal endothelial guttae. So the corneal endothelial, presence of the corneal endothelial guttae indicates the high chances of the endothelial decompensation. Okay, so if a specular count is less than 2000, we always have to take precautionary measures like use high molecular weight viscoelastic. Okay, so use reduced amount of energy when you're doing phaco, especially if it's a hard cataract. Okay, take adequate measures to dilate the pupil adequately. So these steps have to be taken when we are operating on a patient having a very low endothelial count. So this instrument is a Bausch and Lomb keratometer. Okay, this is the Bausch and Lomb keratometer. This is a manual keratometer. Okay, this is your auto refractometer. Okay, the auto refractometer, it also functions as a keratometer and a refractometer. Okay, it also helps in measuring the corneal curvature. It also helps in measuring the refraction. Okay, so this is the auto refractometer. This is the manual keratometer. In the manual keratometer, we adjust the Myers in such a way that the minus and the plus coincide with each other. So we get the reading along the vertical and the horizontal meridian, the horizontal and the vertical meridian. So this is a keratoscope. This is a Placido's disc. Placido disc. Okay, this instrument is your pentacam. The last instrument is the Galilei. Okay, so this is used for corneal topography. What is corneal topography? Corneal topography is mapping the surface of the cornea. So in case the patient has an abnormal corneal surface, like the patient has an ectasia like keratoconus, this maps will show an abnormal reading. Okay, so which is the most sensitive scan in the pentacam to detect the presence of a corneal ectasia? It is your Bellin-Ambrosio display. The Bellin-Ambrosio display on the pentacam is currently the most sensitive test for detecting a corneal ectasia. to detect the corneal ectasia. Okay, so this can be a potential question for your INICET. So the Bellin-Ambrosio display is also known as the bad display. The bad display stands for Bellin-Ambrosio display in a pentacam, which is most sensitive for detecting a corneal ectasia. Okay, so we come to the questions. So the corneal transparency is maintained by all the following except. So the hydration of the corneal epithelium, the widely separated collagen fibrils, the unmyelinated nerve fibers, the mitotic figures in the central cornea. So remember, the cornea is in a dehydrated state. The dehydrated state of the cornea is mainly maintained by the corneal endothelium. The corneal endothelium maintains the dehydrated state of the cornea. So this is the wrong answer. The widespread collagen fibrils, this is your Morris theory of regular arrangement of the fibrils. This is the unmyelinated nerve fiber. Yes, we know that the nerve fiber is unmyelinated, and also the mitotic figures help in maintaining the transparency. Okay, so the next is so we discussed the hydration of the corneal endothelium, the various factors maintaining the transparency of the cornea, the particular arrangement of the corneal lamellae, the avascularity of the cornea, the related state of dehydration of the cornea, the active metabolism, presence of mitotic figures in the cornea, and the high difference in the refractive index of the cornea and the hair, which is important factors maintaining the corneal transparency. Okay. Okay, the corneal endothelium ion exchange pumps are inhibited by. Okay, so they've asked, this is a names question, which of the factors are responsible for maintaining the ion exchange pump in the cornea? So inhibition of anaerobic glycolysis, activation of anaerobic glycolysis, activation of CAMP phosphodiesterase inhibitors, interference with the electron transport change. So remember, activation of the anaerobic glycolysis, the presence of lactate. Okay, presence of lactate in the cornea is what is responsible for the metabolic acidosis. This metabolic acidosis is responsible for the inhibition of the corneal endothelial pump. So activation of anaerobic glycolysis results in the accumulation of lactate in the cornea. The accumulation of lactate is what results in the metabolic acidosis, which results in the inhibition of the corneal endothelial pump. So the inhibition of the corneal endothelial pump will result in failure of failure of maintenance of the transparency of the cornea, which is responsible for the corneal edema, and later this may progress into a pseudophakic bullous keratopathy. Okay, so anaerobic glycolysis is one of the factors inhibiting the corneal endothelial pump. Okay, so keratometer is used to assess the thickness of the cornea, the refractive power of the cornea, the astigmatism, and the curvature of the cornea. What did I tell you? The curvature of the cornea is one which is detected by the keratometer. The thickness of the cornea is determined by the pachymeter. The pachymeter measures the central thickness of the cornea. The refractive power and the astigmatism is checked by the autorefractometer. Okay, in bullous keratopathy, there is damage to the endothelium, the epithelium, the stroma, and the basal lamina. So I told you the failure or damage to the endothelial sodium potassium ATPase pump will result in the pseudophakic or phakic bullous keratopathy. The bullous keratopathy, the reason for bullous keratopathy is failure of the endothelial pump. Okay, so the fluid-filled bullae are formed in the epithelial layer of the cornea due to the endothelial dysfunction. So remember, in an endothelial pump dysfunction, the fluid-filled bullae are typically in the epithelium. They are seen in the epithelium. Okay, the fluid-filled bullae are seen in the epithelium. Okay, next, pachymeter is used to study the corneal endothelium, study the thickness of the cornea, measure the depth of the anterior chamber, measure the field of vision. What did we discuss? Pachymeter is used to measure the central thickness of the cornea. Okay, so corneal guttae is seen in endothelial corneal dystrophy, epithelial corneal dystrophy, corneal aberration, vitamin A deficiency. So I showed you the picture of the specular microscopy, which shows the presence of corneal guttae. So corneal guttae is a endothelial corneal dystrophy. Okay, so the corneal layer which is responsible for detrusescence. What is detrusescence? So Detergescence means relatively dehydrated state. So which is the layer which is responsible for the dehydrated state of the cornea? It is your corneal endothelium. So the endothelial pump is responsible for maintaining the cornea in a dehydrated state. Okay. So with this, we finish the class for today. So tomorrow we will discuss about the various keratitis, the fungal, viral, and bacterial keratitis. Okay.
Good evening to all of you. Today, and this you see a beautiful campus of Speed Residential Village. And if you have an opportunity, you can definitely come and stay here and study. It's really wonderful and awesome. Can we go to the class? We can open the PowerPoint slide. Yeah. So here we are with a thyroid today. Expected question for INICET November 2021 and can be for NEET 2022 and any of the upcoming exams. This will be definitely useful in discussion. Thyroid is a very important topic, a question based out of it. You can see a patient following thyroidectomy is being extubated. The anesthetist realized that he removes the tube. The patient begins to have recurrent cyanotic spells. Which of the following could be the cause? That means always the thyroidectomy is done under general anesthesia with a transverse cervical incision and then reflecting of the flap above and below and isolating the right lobe and left lobe of the thyroid and the isthmus. And if you want to do a hemi, you do it on one side. If you do want total or subtotal, do on the both side. And then you will see, look into the superior thyroid artery, which is a branch of external carotid, and you will see the inferior thyroid artery, which is a branch of thyrocervical trunk of subclavian, and predominant blood supply to the thyroid. And you can see the nerve that is accompanying superior thyroid artery will be superior laryngeal nerve, and the nerve that accompanies the inferior thyroid artery will be recurrent laryngeal nerve. Understood? So, in the process of ligating, so whenever you look into the anatomy, when you see the process of ligating the blood vessels in order to do a thyroidectomy, you suppose this is the thyroid, correct? This is the thyroid, and this is the superior thyroid artery, if suppose, okay, and this is the inferior thyroid artery, yes, from thyrocervical trunk, from subclavian, and this is the first branch of external carotid artery, correct? And this is subclavian artery. And you'll have one artery called Atria thyroida ema, Atria thyroida ema, which is from arch of aorta. Understood? Now, whenever you look into the nerve, that's also a part of this artery. The nerve that is closely associated with the superior thyroid artery. This is the superior thyroid artery, branch of external carotid. This is the superior laryngeal nerve. Whenever you see the inferior thyroid artery, this is the inferior thyroid artery, and the nerve that is closely associated is the recurrent laryngeal nerve, correct? So this is normal anatomy. We always say when you want to tie the inferior thyroid artery, tie far away. If you want to tie the superior thyroid artery, this is the superior thyroid artery, you will tie very close to the gland because to avoid the nerve injury, correct? To avoid the nerve injury, I repeat, the superior thyroid artery is the first branch of external carotid artery. Inferior thyroid artery is a branch of thyrocervical trunk, a subclavian artery, and the nerve that are closely associated with this artery of superior thyroid artery is superior laryngeal nerve. And if you see the inferior thyroid artery, the nerve that is closely associated with the artery is the recurrent laryngeal nerve. So in order to avoid the nerve injury, superior thyroid artery will be tied close to the gland and inferior thyroid artery will be tied away from the gland. So during the process of thyroidectomy, to tie the blood vessels to ensure hemostasis, there could be a nerve injury or there could be a slippage of the ligature that you have tied to the arteries, correct? So you can see all these are relevant options for cyanotic spells or respiratory distress, But the most appropriate answer is bilateral recurrent laryngeal nerve palsy, because the card will come to the median position and it will be the median position and the patient cannot breathe. Yes, and if you see the laryngeal inlet, it will be almost closed and you can't extubate and the patient can go for cyanosis. You can ask me a question, sir, whether or not an hemorrhage or edema can cause this? Superior laryngeal nerve palsy will cause loss of high pitch tone because superior laryngeal nerve gives external laryngeal nerve and internal laryngeal nerve. There are two branches. Superior laryngeal nerve gives a branch called external laryngeal nerve and gives an internal laryngeal nerve. Internal laryngeal nerve is sensory and external laryngeal nerve is motor. External laryngeal nerve supplies what? External laryngeal nerve supplies cricothyroid muscle. So the function of cricothyroid is the tensor of the vocal cord. If the tensor function is lost, the patient will lose the high pitch tone. Loss of high pitch tone will be the typical feature of superior laryngeal nerve injury. Understood? Now, so that option is ruled out. When we come to edema and hemorrhage, in case they ask you a question, what question they can ask you? The most common cause of respiratory distress following thyroidectomy, following thyroid surgery, thyroidectomy. The right answer is edema, laryngeal edema. Understood? And the most common cause of laryngeal edema is tension hematoma. The most common cause of tension hematoma is slippage of ligature. Slippage of ligature from superior thyroid artery. So what you will do? You will release the skin sutures. This mostly happens in the ward after shifting the patient. If it is going to happen in the theater, you will control the hemorrhage. You will tie the bleeding vessel, right? So this will usually encountered. This usually is encountered in the after shifting the patient in the recovery room. So in the recovery room, you will remove the skin sutures and immediately you will shift the patient to the theater and give high dose steroid. High dose steroid, endotracheal intubation and exploration and search for the bleeding vessel and tie the bleeding vessel. Understood? So this is the procedure that you need to follow. So what I'm trying to tell you is the edema and hemorrhage. These are little late. That means how late? You can see in the recovery room, immediately after the recovery room. If this is going to be the cause, definitely you would have given a steroid or controlled the hemorrhage and definitely you would have extubated the patient. But if it is because of bilateral recurrent laryngeal palsy, you are not able to extubate and the patient is going for recurrent cyanotic spells. Okay? And what to do? You need to ventilate the patient and you need to give steroid, and the treatment of choice is going to be lateral arytenoidopexy. Lateral lateralizing the vocal cord. It can be done endoscopically or by open surgery. Yes, so this is what you need to do. So I think things are very, very clear. This is a very important complication. Nerve injury is an important complication. And also respiratory distress because of edema and hemorrhage or hematoma is an important complication. I think I have explained it very, very clearly to you. And this is a very, very important question for exam. Hope you have understood very clearly. And Subiston, 21st edition is the latest edition, page number 915. And let us go through it and what it says. Through line by line from the standard textbooks. Bilateral recurrent laryngeal nerve injury is a resultant resting vocal cord position in midline. See that? And can lead to airway compromise and potentially require a temporary or permanent tracheostomy. If you are going to delay the procedure of lateralizing the vocal cord, then you have to go for a tracheostomy, temporary or permanent. And the risk factors of recurrent laryngeal nerve include low surgeon volume, that means little inexperience, reoperative thyroid surgery, that means you do redo, or most extensive surgery of malignancy, Graves' disease, or large substernal goiter. So all those difficult surgeries and malignant surgeries involving thyroid can cause this problem. That's what it says. Okay, I think we have done very, very clearly on the nerve injury today, and I request all of you to go through the sessions, and definitely it will be useful for your upcoming INICET and NEET 2022. Wish you all the best. Thank you.
Hello, am I audible? Can you just confirm if I'm audible? Okay, so hi everyone, I'm Dr. Sneha, and today we'll be discussing on the topic of cord prolapse in obstetrics. All right. So even if not for MCQ, also this is a very important topic because this is one of the obstetric emergencies for the baby. If you don't act quickly, it can affect the fetus. It can cause fetal distress and even death of the baby. All right, so it's important to recognize this problem immediately and act quickly. So let's look at the types of cord prolapse. When you come to the type of cord prolapses, there are actually 3 types, and you need to know what each terminology means. So let's look at this first picture. Here, if you see the membrane is present, this thin black line is a membrane, the baby's head, and the cord lies at the side of the baby. So if you're doing the pervaginal examination, you will be feeling only the baby's head, but then you won't be able to feel the cord. So the cord is hidden inside, but it is pressed against between the baby and the uterus or the surrounding structure. That this type of cord occlusion is called occult cord prolapse or occult cord presentation. Okay. This usually presents in clinical scenario like patient will be in labor and there will be variable decelerations on the CTG. Okay. And later, if this doesn't recover and when you're doing a cesarean section, you will notice that the cord is on the side of the baby, and during each contraction, the cord is getting pressed between the baby and some other hard structure, and that's why it's causing the deceleration every time there is uterine contraction. This is the first type, occult type. The second type, if you see, the membrane is present here also, but the cord is seen below the baby's head. So this type is called as cord presentation. Very important thing is that the membrane will be present here. Okay, the membrane is present and the cord is below the head. This is usually incidentally found when you're doing an ultrasound for the baby for some other reason like finding out the liquor or weight of the baby. You instantly find out that the cord happens to be below the baby's head. If this happens at more than 37 weeks at term, you'll have to advise the patient for cesarean section, because if you do rupture of membrane or induction of labor with this, the first part that is going to come out is the cord, and it can cause proper cord prolapse and hypoxia to the baby, and the baby's health will be compromised. Okay. The third type is the proper overt cord prolapse. Okay. In this case, the membrane will be absent, membrane will be ruptured, and that is why the cord will be seen coming out into the vagina or sometimes even outside the introitus. Okay, and the cord gets compressed between the baby's fetal skull and the mother's bony pelvis, a soft structure that is getting compressed between two bony hard surfaces decreases the blood flow to the baby, and it can cause fetal distress, and if you don't act immediately, it can eventually lead to stillbirth as well. Okay, so 3 types: occult when it is lying on side of the baby, second is cord presentation when the membrane is present and there is cord in front of the baby's head, and third is overt cord prolapse where the membrane is absent and the cord is either in the vagina or in the introitus. So when do you suspect cord prolapse? You can anticipate few things in obstetrics, and by anticipation, you can be ready to manage them when it happens. Okay. So first is basically when the baby's head fits snugly into the mother's pelvis, there is no space for the cord to come in between the baby's head and the pelvis. But if there is a space between the baby's head and the mother's pelvis, the cord can easily prolapse in between this area, and that is when cord prolapse can happen. So logically, if you think about it, when are these conditions where there can be a gap between the baby's head and the maternal pelvis? First is in prematurity. Prematurity, the baby's head will be small because the baby is not fully developed yet and it will not snugly fit into the pelvis. Second, when there is polyhydramnios, too much liquor, the baby's head will not get fixed into the pelvis. The baby's head will be floating somewhere on the top. Okay. Third will be multiparity, especially grand multis, very lax abdominal wall. The baby's head will not get engaged very easily. So again, another reason. Fourth will be multiple gestation. Two babies, each baby will be slightly smaller than a singleton, and especially before the delivery of the second baby. First baby, usually there'll be no problem. Second baby, it will take time for the presenting part to come down and get engaged. And during this time, if the membranes get ruptured, there's very high chance that the cord might be the first thing that comes out. Okay. And the last important reason is malpresentations. Instead of the head, if the presentation is like breech, a soft part, or there is no lower pole at all, such as transverse lie, again, it's easy for the cord to get prolapse between the fetal presenting part and the pelvis. Okay, so these are the conditions. Go to the case scenarios and see if any of these buzzwords are present. The other cause, main reason is you causing the cord prolapse. Sometimes the doctor can be responsible for causing the cord prolapse, and that is whenever you do a pervaginal examination for the patient during labor. So first, when you're doing artificial rupture of membrane, especially when the head is not engaged, head is very high and floating, you rupture this membrane, the first thing that comes out can be the cord because the head is not engaged yet. Second, when you're doing amnio infusion, you're introducing a small tube, IV line like tube, catheter set inside the through the cervix into the womb, and in that process you'll be lifting up the baby's head to make sure that the tube is well inside the womb. So when you're lifting up the baby's head, sometimes the cord can come out through that space. Okay. And third is when you're doing procedures such as attaching a fetal scalp electrode. Fetal scalp electrode is another method of monitoring the baby's fetal heart rate. You might not see it very commonly in India. And when you're doing procedures such as internal podalic version, again, because you're putting your hand inside and trying to deliver the baby, before you deliver out the baby, the cord can come out through that space. So these are some of the situations in which you need to suspect, okay? And anytime during delivery, if you see that there are FHR changes, especially variable decelerations. Variable decelerations are a sign of the cord getting compressed. There are many reasons for cord getting compressed, but one of the reasons is a cord prolapse, especially if there is an occult cord presentation somewhere. All right. So let's go to the MCQ. You're instructing an emergency personnel to shift a pregnant woman presenting with cord prolapse to the hospital. In what position will you ask her to be transported in the ambulance? So here, a pregnant patient is diagnosed to have cord prolapse, but she's not in the hospital. She's somewhere in the public place. And you are instructing the person in 108 ambulance or in the ambulance, paramedical, to shift her. And you are advising them to put the patient in a particular position that the head will get lifted up and the head does not compress on the cord for that temporary period when you're shifting the patient. During that short period, you're somehow trying to relieve the pressure, that bony pressure on the cord, right? So what is that position? Is it supine, left lateral, exaggerated Sims, or knee chest position? Let me just show a picture of what exaggerated Sims look like. Sims position is when you put the patient on left lateral and you ask her to flex one of the legs. Okay. Exaggerated Sims is when you put a pillow or something below the hip so that the hip is slightly elevated. It is at a higher position than the head. So by doing this, if you can imagine the baby's head to be here compressing the cord, when you're lifting up the head might get dislodged and go above, relieving the compression on the cord. All right. So this is one position that can be used temporarily before you deliver the baby to relieve the pressure on the cord. Knee chest position. This is knee chest position. The mother is lying on her knees and on her chest. Okay. Again, you can see that the hip is at a higher level compared to the mother's head. So by gravity, the baby's head will slightly dislodge towards the mother's head end. So the pressure on the cord might get released. So these are all temporary measures that you can take before you shift the patient for immediate delivery. All right. So supine will not cause any such kind of dislodgement to the head. Again, left lateral also, the patient is in a plain surface, so it will not cause any dislodgement. So your option will be either exaggerated SIMS or knee chest. So just think, if you're shifting a patient in an ambulance, which do you think will be a safer position? You put the patient in ambulance like this in knee chest position, she roll over or she might fall. Lying on a cot like this with a wedge or a pillow below her hip might be a safer option when you're transporting her in a ambulance or anytime when she's on the road. Okay, so when in transportation, this might be a better position, whereas knee chest is when the patient is having home delivery. For example, a midwife or a nurse is conducting the delivery and this happens, or else in the hospital, just before you shift her to cesarean section to immediately deliver the baby. At these situations, when you're not shifting the patient, at that time, this knee chest might be a better option. So the answer here will be exaggerated SIMS. All right. So you have once cord prolapse occurs and there is fetal distress, your aim is to immediately deliver the baby so that it does not cause significant hypoxia, and eventually it can even lead to fetal death, as I already mentioned. Okay, so you can do few measures to relieve the pressure on the cord before you shift the patient, or when the staff is preparing to shift the patient, like you're inserting a catheter, IV line, you're arranging for a stretcher for the patient to be sent to the theater. So it will take around 5 to 10 minutes, right? From the time you take the decision to do a cesarean section to shifting the patient to the theater. So during this time, you can do certain measures to relieve the pressure on the cord. All right. First is change the position of the mother. As already mentioned, your aim is to put the hip up and the mother's head down so that by gravity, the baby's head will be discharged. So you can either put the patient on steep Trendelenburg or like I said, knee chest or exaggerated SIMS. And this can be done by anybody. It's not necessary that a doctor should do. Even nurses, midwives, anybody who's around the patient can instruct the patient to be put in this position. Second, you can fill up the patient's bladder. Okay, by filling up the bladder fully, it will dislodge the baby's head above. And again, this will decrease the compression on the cord. Okay. So these are some things that you can do to relieve the pressure on the cord. Whereas when you're planning to shift the patient, at that time, you can give her terbutaline injection. Terbutaline causes uterine relaxation. Okay. So when the patient is in labor, uterine contraction itself can cause compression of the cord. So by relaxing the uterus, you're taking away one of the stress factor that can cause further cord compression, that is the uterine contraction. Okay. So you can give terbutaline and make sure that fetal heart rate is monitored continuously till the theater. Even before you make the incision, you have to make sure that the baby is alive, because you don't want to perform a cesarean section on a dead baby. Okay, the cause for it, the meaning, the whole purpose of it is lost. So you have to make sure that the FHR is monitored throughout the process till you make the first incision or till you deliver the baby. All right. So these are some of the steps that you can take to relieve the pressure on the cord, and also certain measures that you can do before you shift the patient for cesarean section, right? And another important point is using your fingers, you can push up the baby's head. like doing a pervaginal examination, but you push the head up so that you create a space between the baby's head and the mother's bony pelvis so that the cord is not compressed between the two bony structures. Okay. What you should not do, definitely, you are not supposed to replace the cord inside the mother's womb again. Don't try to push it back inside the womb again, because it can cause occult cord compression. You don't know where you're pushing the cord inside. You don't know whether that cord is getting compressed between any other baby's part and any other mother's part. You can't see inside the mother's womb, right? So don't try to push it back inside the mother's womb. This is a definite no in cord presentation. All right. So let's look at another FAQ. You have done an artificial rupture of membrane for a primigravida at 38 weeks and notice that there is a sudden bradycardia on CTG. So there is some sign of fetal distress after doing ARM. Definitely you can suspect cord prolapse, right? On examination, you notice loops of cord outside vagina. Now you have diagnosed cord prolapse. Cervix is fully dilated, membranes are absent, clear liquor draining, vertex is at +2 station, position is left occipital anterior. How will you deliver her? So we know at this point that the baby has to be delivered immediately, the fastest route that is possible in this scenario. Okay. So let's see which is the fastest route in the options given. Is it emergency LSCS or instrumental delivery, or you just give an episiotomy and wait for the patient to push the baby out by herself, or do you give fundal pressure? Okay, as a general rule, do not give fundal pressure to the mother. It is not respectful maternity care and it is quite painful for her. So any option, any question, if you see fundal pressure, please strike it out. It is not an option. And by giving episiotomy, you have to wait for the mother to push by herself and deliver. So you're losing precious seconds, precious minutes where you can save the baby. So your options are either emergency LSCS or instrumental delivery. Now look at this scenario. The patient is in second stage. The baby is in +2 station. That is, it is almost delivered out, right? So you might take around 20 to 30 minutes to shift the patient to theater, give anesthesia and deliver out. But if you apply an instrument, within the next few minutes, you can deliver out the baby. So in this condition, in this clinical scenario, instrumental delivery might be the best option to deliver out the fetus in the fastest route possible. So let's quickly look at management of cord prolapse. You have diagnosed cord prolapse, what next? So the first thing is you check if the baby is alive or dead. Okay, very possible, because within few seconds or few minutes, it can cause hypoxia and the baby can die. Suppose if the baby has already died, there is no use of shifting the baby immediately to theater to do a cesarean section or applying an instrument. You just have to augment and await for normal vaginal delivery. Okay, because you're not trying to save the baby anymore, no use. If the baby is alive, then you do a PV examination and see in which stage of labor she is in. If the cervix is still not fully dilated, that is, she's not in second stage, she is very far away from being delivered, or if the head is very high up, then you shift the patient for emergency cesarean section. This will be the fastest way. Suppose if the cervix is fully dilated, that is, she's entered the second stage of labor. Next thing is you check the presentation. If the baby is in transverse lie you cannot conduct a normal vaginal delivery. So again, this will be emergency cesarean section. Okay. If the baby's head is +2 or below, it is almost there, right? So you can apply an instrumental delivery based on the baby's head rotation and other contraindication. We decide between forceps or vacuum. Suppose it happens to be a breech presentation. Okay, we saw that malpresentation is one of the risk factors for having cord prolapse. a breach was not detected antenatally, she happens to come in labor fully dilated, and again the breach presentation it +2 or more. Breach is almost delivering out. At this stage also, cesarean section might not be the most optimal option, because most of the time, by the time you shift the patient, deliver, the breach will be out. Okay, so you will have to deliver the baby normally. So here you will do breech extraction, total breech extraction. Not assisted, not spontaneous. You will have to deliver the baby out immediately. So you take control of the situation, grab hold of the baby's legs and pull it out. So this will be the fastest way possible. Okay, total breech extraction. So this is a brief outline of how you manage cord prolapse once you diagnose it, right? So this is the end of today's session, and I hope that was useful. Tomorrow we'll see again on one of the important topics from labor module. All right, thank you so much.
Good evening, one and all. Today in leprosy case discussion, MCQs discussion, we'll discuss a few important leprosy related MCQs which they might ask in exams. So the first question we will discuss here is identify the type of leprosy shown in this picture. What you can see in the picture is a shiny papule and a shiny nodule over the face, along with the background skin seems to be a little bit infiltrated. This is the only finding you can see here. Some loss of fibrosis is there, that is there. Otherwise, the patient is not having any classical leprosy lesion. So this is a specific type of leprosy which is named as histoid leprosy. Histoid leprosy is the answer. Pluvio leprosy and histoid leprosy are the special types of leprosy you should be knowing before going to exam. Apart from that, there is nothing called facial leprosy. Leprosy has some specific finding, especially in case of lepromatous leprosy, it has some specific findings in face. Apart from that, you don't have anything called as facial leprosy. And nodular leprosy also, it's not a separate type of leprosy. It's just nodules you can find in any spectrum of leprosy. So we'll see about histoid leprosy. It's a type of lepromatous leprosy only. But usually the patient presents with dapsone resistance, and what you will see here is shiny papule, as I described in the lesion already. Shiny papules and nodules with intervening normal skin will be there, and in skin biopsy you will find a specific feature in case of histoid leprosy called as spindle-shaped foam cells will be there. This foam cells will be arranged in a storiform pattern like dermatofibroma, or in a linear pattern. So this pattern of arrangement and elongated spindle-shaped foam cells is called as histoid habitus. Then other special type of leprosy is lusioleprosy. Lusioleprosy is a non-nodular form of lepromatous leprosy, where you will find diffuse infiltration over the face. You will not have specific nodules or papules or any other isolated skin lesion. You will have diffuse infiltration over face, and this lusioleprosy will lead to absence of wrinkling over the face. That's why it is called as lepra bonita, or pretty leprosy, or beautiful leprosy. So in this you'll find no wrinkles or shiny younger face due to diffuse infiltration will be there. Let's move on to next question. What is the order of sensation loss in leprosy? So we know that there will be sensation loss in leprosy. In what order of sensation it will be lost? It is asked. It is nothing but the A option. Hot cold differentiation will be the earliest sensation to get lost in case of leprosy. Patient will not be able to differentiate between hot sensation and cold sensation. This you can test in such patients with a test tube with the hot water and the cold water. Hot water you can test with +7 degrees Celsius above body temperature, and cold water -7 degrees Celsius below the body temperature. So the patient won't be able to differentiate between hot and cold in the area where leprosy lesion is present. So this is the earliest sensation to be lost in case of leprosy. Apart from that, second sensation to go is cold, then hot, then light touch will be among touch. You will have light touch will be lost in the first, and then followed by pain, and deep touch and pressure will be lost in the later stages. Next question, madarosis is seen in which type of leprosy? When I was explaining about lepromatous leprosy and other types of leprosy, I told madarosis, which is nothing but loss of eyebrows. This loss of eyebrows is seen in case of lepromatous leprosy only. This loss of eyebrows, actually madarosis is of two types: supraciliary madarosis and ciliary madarosis. Supraciliary madarosis is loss of eyebrows, and ciliary madarosis is loss of eyelashes. Both supraciliary madarosis and ciliary madarosis will be seen in case of lepromatous leprosy only. So you should know about eye changes in leprosy, what all will happen. How eye is infected in case of leprosy is that it is due to direct invasion of, it can be of 4 types. It can be due to direct invasion of M. leprae in eyes and surrounding tissues. Bacilli invading the eye tissues directly and causing the eye changes. And the second way of infecting eyes is it just enters and it reacts with the tissues, and it causes inflammatory lesions, and it sensitizes the ocular tissue to the lepra antigens and forms inflammatory lesions, and uveitis, iridocyclitis, all those things, episcleritis, all those inflammation can happen. Third thing is it reacts to form granulomas in the nerves, causing nerve palsy. And fourth way how a leprosy bacilli can infect eye is granulomatous infiltration of the surrounding structure may lead to all the functional deformity, like abnormal blocked nasolacrimal duct, will lead to dacryocystitis. All those surrounding structures will be involved to involve the eye. And then followed by this, because of this exposure in an inflammation, and because of M. leprae exposure, this leads to exposure keratitis and corneal ulcer. And in corneal ulcer, you can have a secondary infection also. It also plays an important role. So eye findings, eye abnormalities in leprosy, main findings, these are all the findings you should remember. Mainly it causes cranial nerve palsy. 5th and 7th cranial nerve will be involved, and it causes madarosis. As I told earlier, supraciliary madarosis, which means loss of eyebrows, and ciliary madarosis, which means loss of eye lashes, and scleral nodules, limber at the sclerocorneal junction. At limbus, you will feel you will have scleral nodules, and iris pearls will be there. In iris, you will have collection of acid fast bacilli, this lepra bacilli with macrophages, that is called as iris pearls. Along with that, you will have iridocyclitis and uveitis. This will lead to trabecular blockage leading to glaucoma, and repeated attacks of glaucoma can lead to pannus formation and cicatrization in the as a later stage. So these are all the findings you should remember. And who is at the high risk of having ocular lesions in case of leprosy is if the patient is having any skin lesion over the face, or if he is untreated for longer time, and any patient of reaction is at high risk for having eye manifestation in leprosy, and present or patient is having other ocular pathology. These are all the patients of high risk, patients with high risk for getting ocular lesions in case of leprosy. So in a case of leprosy, potentially sight-threatening lesions are corneal hypoaesthesia or exposure keratitis, or any case of corneal ulcers, lag of thymus leading to corneal exposure leading to keratitis, complicated cataract, recurrent uveitis, and dry eye syndrome. These are all the patients who are at risk, high risk for developing potentially sight-threatening lesion in case of leprosy. This is next question. This is the histopathology of a leprosy patient only. You try to find out the diagnosis or any other finding in case of this patient. So what you can see here is epidermis, it is almost normal. In dermis, you will have some infiltrate, you are having some infiltrates over here. And in the deeper dermis, around the, these are all the sweat glands, eccrine glands. So around the peri-eccrine area, you have an elongated granuloma. So this is peri-eccrine elongated granuloma is a feature of borderline tuberculoid Hansen's. This is a high resolution picture of this same peri-eccrine granuloma. What you can see here is a slipper-shaped epithelioid cells, and lymphocytes are there. So macrophages are there. So this is a granuloma. And this is nerve. So around the nerve also you are finding granuloma. So this is a typical histopathology picture of borderline tuberculoid Hansen's. Next question, try to match the following. Type 1 reaction. Type 1 reaction is a type 4 hypersensitivity reaction. Type 2 is a type 3 hypersensitivity reaction. Drug used in type 1 reaction is oral steroid. Actually, in type 2 reaction also we use oral steroid, but thalidomide is the drug of choice in case of type 2 reaction. So this drug used in type 2 reaction will go to only thalidomide. Drug used in type 1 reaction is steroid. So the answer is type 1 is 1 is for 1C, 2D, 3B, and 4A. So reactions in leprosy, you see the basic differences and how do you treat the leprosy reaction. As I told earlier, type 1 reaction, any leprosy reaction will occur during the treatment only. After starting the treatment, when the patient starting to regain his own immunity, then he will have reactions. So type 1 reaction is a type 4 hypersensitivity reaction. Type 2 is type 3 hypersensitivity reaction. Usually this reaction occurs within few months after treatment due to regain of immunity. And type 2 reaction also occurs after treatment only. Lesions, the clinical presentation of type 1 is the existing leprosy lesion will become red, tender, and painful, and nerve inflammation will be there leading to neuritis. Here, in type 2 reaction, what you will have is a specific finding, multiple drain, painful nodules which will occur in drops and resolves within 24 to 48 hours with pigmentation. This is called as erythema nodosum leprosum, or ENL. Here also patient will have fever and neuritis is a common feature. The main differentiating feature between type 1 reaction and type 2 reaction is ENL lesion will be present in case of type 2 reaction, whereas existing lesion will have redder, tenderness, and painful in case of type 1 reaction. And one more differentiation between type 1 and type 2 reaction is in type 1 reaction, you will have no systemic symptoms. Here in type 2 reaction, patient will have systemic symptoms, hepatitis, arthritis, periosteitis, all those systemic involvement will also be there in case of glomerulonephritis. All those systemic involvements will be there in case of type 2 reaction. And how do you treat a case of type 1 and type 2 reaction? In mild cases, it is treated with both the reactions are treated with NSAIDs only. In severe cases, systemic corticosteroids are the drug of choice in case of type 1 reaction. In type 2 reaction, you can use both either systemic corticosteroids or thalidomide. Usually, thalidomide is said to be the drug of choice in case of type 2 reaction, and it responds very well to type 2 reaction responds very well to thalidomide, and thalidomide controls the reaction within 48 to 72 hours. The dose of the systemic corticosteroids used in case of type 1 reaction is 1 mg per kg per day. In type 2 reaction, the dose is usually higher compared to the type 1 reaction. It is used at the dose of 1 to 1.5 mg per kg per day. So this is all about reactions and their management. With this we'll wind up the session. I'll discuss the remaining few MCQs of leprosy tomorrow, and then we'll go to the next topic. I hope this session was useful to all of you. Thank you.
Yes. So welcome to our anesthesia question discussion. I am continuing my discussion on questions which could come from the topic which is called as anesthesia machine. If you remember, for the last 2 days, we were discussing questions from a topic which was called as anesthesia cylinders. We have covered it very, very detailed. Everything has been discussed, which could be asked in your exam. So today I'm going to take you to a different topic in anesthesia machine, from which a lot of questions are coming, especially in the INICET, AIMS, PGI exams. Okay. So this question is basically about a part of your anesthesia machine, which is called as your flow meters. Okay. So I'll just read out the question for you. All the following facts about anesthesia machine flow meters are true, except the flow meter in the flow in the lower part of the flow meter depends on the viscosity. The flow in the upper part of the tube depends on the density. The flow meters that we use is variable pressure, variable orifice flow meter. Then last option is in a flow meter arrangement containing air, oxygen, and nitrous oxide. Oxygen should always be placed closest to the common gas outlet. If you want to attempt this question, what would be your answer? Right? So anyways, the wrong statement in this particular question is C. Flow meters that we use in your anesthesia machine is constant pressure variable orifice flow meters. Okay. Okay. So to understand this question in some detail, we need to have some background knowledge about the functioning of your flow meter. So what are the kinds of questions that can come from this particular flow meter? Okay. First things first, it can come as an image-based question. Okay, this can come as an image-based question. Simply, they can just put this flow meter into the image, and they can ask what is this particular anesthesia machine component, and you can tell that this is flow meter. So this is one possible image-based question. The second possible image-based question that can come. The second possible thing that can come from your anesthesia machine aspect of it is, right?
Yes. Sorry for the break. I'm continuing my discussion on this particular topic called as flow meters, right? So anyways, I told you the first possible question that can come out of your flow meters is, they can just give you this image in the question and they can tell you to identify the part and you will identify it as flow meter. Okay, you can see that it is a tube here and beneath you can see a flow control knob. I told you flow control knob is something which we call as a part of your intermediate pressure system. Okay, it is the part of an intermediate pressure system, and once you open or once you operate on this flow control tube, it is going to lead to the flow of gases in the upward direction. Okay, and you can see that there is something here in your flow meter which is called as the bobbin, or it is otherwise called as rotameter. Okay, so what is the function of the bobbin? Bobbin helps you to identify what exact flow are you giving to the patient. What exact flow are you giving to the patient? Okay, so this is bobbin, or otherwise called as rotameter. The function of this particular rotameter is to let you know or let you identify what exact flows that you are giving to the patient. So this is your flow meter. One important thing that you should understand about your flow control knob is, when you operate the flow control knob, obviously flow happens, right? This flow control knob is also color coded. This flow control knob is also color coded and it is touch coded. Okay, it is color coded and touch coded. So what is the color? You can see that oxygen is white in color and nitrous oxide is blue in color and air is black in color. Now, in most of the anesthesia machines, you're only going to have two flow meters, which is oxygen flow meter and nitrous oxide flow meter. In some machines, you might have three flow meters, and if there is a three flow meter, the third flow meter would ideally be air. Okay, so if it is air also is present, then air will look like black, oxygen is white and nitrous oxide is blue. Okay, so this is flow control knob, this is the flow meter, and this is the bobbin. Please do identify. One more question is, they can just give you the image and tell you to identify this particular structure belongs to what pressure system, and you can identify it as what? It is a part of your low pressure system. We have already discussed this detail in our discussion which has happened 2 days before. Okay. Now, coming to the question, it is a very, very conceptual question. We need to have a lot of understanding about the flow meter to understand the question. Okay, so let me take you to the functional understanding of a flow meter. How does flow happen in your flow meter, and what are the factors which affect the flow through the flow meter? Okay, right. So as you can see in this particular image, this is the flow control knob. Now, when you rotate the flow control knob in the anti-clockwise direction, flow happens in the flow meter. Okay. Now, what are the things that you should understand about a flow meter? I'm going to draw a flow meter here. Okay. You might think that the flow meter is absolutely like this. No, the flow meter is actually in conical shape. So what is the shape? It is in conical shape. So let me just draw a flow meter here, just like this. Okay, so if you look at the flow meter, it is not exactly one cylinder, it is a conical in shape. So what is the shape? It is conical in shape. So what do you mean by conical shape? You'll know that the lower parts are narrow, the lower parts are narrow and the upper parts are wide. Lower parts are narrow and the upper parts are wide. Right? And you also know that you are going to have a bobbin inside the flow meter. This is otherwise called as rotameter because it rotates. It is otherwise called as rotameter, otherwise called as bobbin. Now, when you switch on this particular flow control mode, gas flow is going to happen. Gas is going to flow through the flow meter like this. Right? So as gas flow happens, what is going to happen? It is going to push this bobbin upwards. It is going to push this flow upwards. Now, let me draw one more flow control or flow meter here. Now, as gas flow happens in this particular direction, it is going to push the bobbin upwards. And this bobbin is going to rest at one particular place where the upward force exerted by your gas will be matched by the downward force which is exerted by gravity. So there is going to be matching of physical forces here. The upward force is basically the gas which is coming from the anesthesia machine, and the downward force is exerted by the gravity. So bobbin will actually rest at a place where both of these are equalized. Okay. Now let us see what are the factors which affect the flow through the flow meter. Okay, factors affecting flow through the flow meter. This is the point from which your question has been formulated. Please do remember, this is a JIPMER question. So it is a previous year INICET question. Okay. So first of all, imagine that gas is flowing through a flow meter like this. So this is basically a small tube and you are making the gas or air move through a small tube. Now, whenever you try to make a gas flow through a small tube, obviously it encounters something which is called as a resistance. It encounters something which is called as a resistance, right? So what is the resistance that is offered to the flow of gas in your flow meter? You have a resistance which is in the form of your rotameter. So whenever a gas is trying to flow, it encounters a resistance which is in the form of rotameter, right? So what happens if flow encounters resistance? When flow encounters resistance, there is going to be some decrease in the pressure of your gas flow. So when flow encounters resistance, there is going to be a dip in pressure. There is going to be a pressure drop. There is going to be a pressure drop. So when gas flow happens through your flow meter, there is going to be some amount of pressure drop. Now, that pressure drop that is going to happen is directly proportional to the resistance which is offered to the airflow, as I've already mentioned, right? And I've already told you that the resistance that is produced to the airflow in a flow meter is because of your bobbin, right? So there is another important equation by which you can understand this particular concept. The resistance offered to the gas flow is directly proportional to, or it is related to the bobbin. And what exactly is related, or how is exactly are they related? The resistance offered is directly proportional to the weight of the bobbin divided by circumference of the bobbin. Okay, so pressure drop happens because of resistance to airflow. Resistance happens because of the bobbin. How much resistance is going to happen? It is equal to weight of the bobbin divided by the circumference of the bobbin, right? Now imagine your airflow happening in your flow meter. This is the narrow part of the flow meter. This is the middle part of the flow meter. This is the upper part of the flow meter, right? Now, the weight of the bobbin and the circumference of the bobbin is going to be the same here. It is going to be the same here. It is going to be the same here. Yes or no? So, the weight of the bobbin divided by the circumference of the bobbin is constant at any place in your flow meter. What does that mean? It means that the resistance offered to airflow or gas flow at any point in your flow meter is a constant. So if the resistance offered to airflow is constant, then the pressure drop that happens in your flow meter is also a constant. You take this point as A, you take this point as B, you take this point as C. Wherever it is, the resistance offered is weight by circumference of the bobbin, and that is the constant. So resistance is a constant, hence pressure drop is a constant. So how much amount of pressure drop here happens? That is going to happen in B, that is going to happen here in C. So because the pressure drop that is happening in your flow meter is a constant, your flow meters are called as constant pressure flow meters. It is not because they maintain a pressure. It is because they have a constant pressure drop. So they are called as constant pressure flow meters. They are called as constant pressure flow meters. Now, no, this is not the full name of your flow meter. Let me tell you one more important aspect of a flow meter. Now, imagine I'm looking at the flow meter from above. I'm looking at the flow meter from above. So if I look at the flow meter from above, what am I going to see? I'm going to see a big circle. So this is how the flow meter is going to look like, because it is basically a circle. It is basically a circle. It is conical in shape, but it is basically a circle, right? Now, inside this particular main circle, what I'm going to see something which is called as the bobbin. Yes or no? So there is going to be an inner circle. Right, inner circle. Now you are going to make the gas flow like this through the flow meter, right? So when gas is going to flow through the flow meter, obviously it is encountering a resistance. So what is this gas going to do? It is going to go through the sides of the flow meter like this. It is going to go through the sides of the bobbin, and it is going to go. So if you look at the sides, they are basically in a shape of circle, right? This is the area that is left for gas to flow. Whenever there is a bobbin encountering the resistance to airflow, the air is going to go through the sides of the bobbin. And if you're looking it from above, you'll know that this is basically the space which is left between two circles. The outer circle is obviously the flow meter, and the inner circle is basically your bobbin. Yes or no? So this is the space, and this space is what is called as annular opening. This space is what is called as annular opening. Okay, the space is called as annular opening. Now imagine what is happening to the size of this annular opening at different points. Now this is one point A, this is one point B, this is one point C. Where A is the narrow part, A is the lower part of your flow meter, and you can see that at the lower part of the flow meter, this opening is very, very less. At B, you can see that the opening has become wider. And at C, you are seeing that the opening is further wide. So what does that mean? As gas flow starts flowing through the flow meter, the annular opening size is going to increase. The size of annular opening increases as you proceed from the lower aspects of the flow meter to the upper aspects of the flow meter. So the orifice that is there for your airflow to happen is variable. It is narrow at the lower parts, it is wider at the middle part, and even more wider at the upper part. So that is why your flow meters are not just called as constant pressure flow meters, they are called as constant pressure variable orifice flow meters. Variable orifice flow meters. So what are they called as? They are called as constant pressure variable orifice flow meters. I mentioned about the pressure drop, I mentioned about the orifice. So I mentioned two factors which can affect the flow through your flow meter. Third important aspect is, see, at the lower parts of your flow meter, let me draw one fresh image here. Okay. This is your flow meter once again, and this is the lower part of the flow meter, and this is the upper part of the flow meter. Okay, so this is the space that is present for air to flow at the lower parts. This is the space that is left for air to flow at the upper parts. So because you are having a more streamlined and narrow space here at the lower parts, the flow is going to be laminar here. And because you are giving a lot of space for air to follow or the flow at the upper parts, the flow is going to be disturbed. So the flow becomes turbulent here. Okay, so what do you want to know? You should understand that at lower parts or narrower parts of your flow meter, the flow that you are going to achieve, what kind of physical flow that are you going to achieve? You are going to achieve more or less laminar flow. Similarly, when you are going towards the upper aspects of your flow meter, when you are going at the upper aspects of the flow meter, the flow is going to be more turbulent. The flow is going to be more turbulent. So laminar at the bottom, turbulent flow at the upper aspects. What is the significance? There is a law which governs laminar flow, and that law is called as Hagen-Poiseuille law. That law is what is called as Hagen-Poiseuille law. Hagen-Poiseuille law states that if the flow is laminar, then the resistance offered to flow is directly proportional to the length of the tube. It is directly proportional to the viscosity of the gas or liquid, and inversely proportional to the fourth power of radius. You don't have to remember the equation. Just remember that laminar flow depends on the viscosity. So at the lower aspects of your flow meter, flow is predominantly dependent on the viscosity of the gas. Whereas when the flow becomes turbulent at the upper aspects of your flow meter, what happens? When it is turbulent flow, it is not viscosity which governs the flow. It is the density of the gas which governs the flow. The laminar flow depends on viscosity, turbulent flow depends on density. So what do you want to understand? At the lower parts of the flow meter, the flow is predominantly viscosity dependent. At the upper part of the flow meter, the flow is density dependent. The lower parts of the tube is characterized by laminar flow. The upper parts of the tube is characterized by turbulent flow. Okay. Please do remember that in mind. And one more important point, I told you that it is a constant pressure variable orifice device. And the constant pressure is mainly because you're having a bobbin whose weight by circumference is a constant. Sometimes when you are using flow meters for a very long period of time, some mud can accumulate over your particular bobbin, and that can lead to increased resistance, and that can lead to flow meter malfunction. Now, this was a Madhya Pradesh State Board exam, PG exam question, like some long years back. What could lead to failure of flow meters? And one option was mud over your flow meter. Okay, the reason why that can lead to the failure of whole flow meter is it increases the weight of the bobbin. So weight by circumference is going to change. The resistance of flow to flow is going to change. So it can undershow the correct flow rate or undershow the flow rate. Okay, so I discussed three important factors already. First was the pressure drop factor. Second factor was the variable orifice factor. Third factor was the physical properties of gas such as viscosity and density. And the fourth factor that affects flow through your flow meter is the temperature and pressure, the ambient temperature and pressure. And why do you think ambient temperature and pressure can affect the flow through your flow meters? Because temperature and pressure, they affect the viscosity and density of gas as well. So because they can alter the physical properties of gas, they can also alter the flow through the flow meter. So all in all, you please understand that. So the four important factors which can affect the flow through your flow meters are: one is pressure drop, second is variable orifice, third is physical properties of gas, viscosity and density, fourth temperature and pressure. Okay, this can also be an all except question or one among the following affects the flow through the flow meter question. Remember the Madhya Pradesh exam question where they asked about mud over the flow meter. Okay, and I'm now taking you to the last aspect of your anesthesia machine discussion and last aspect of flow meter, and that is how should your flow meters be arranged in your anesthesia machine. You know that finally flow meters will have, please do remember the low pressure system, flow meters ends up with a common common manifold where you have the vaporizers, then there is a pop-off valve, and finally common gas outlet. So your flow meters finally eventually lead to common gas outlet from which gas is taken to the patient, right? Now we are basically going to have three gases. You can have oxygen, air, and nitrous oxide. So how would you arrange these three gases in an anesthesia machine? Where will your oxygen position come? Your oxygen position should always come downstream or nearer towards the common gas outlet. What can happen if oxygen is placed somewhere other than the last position or the nearest to the closer common gas outlet should be oxygen. Now, if you're trying to place oxygen somewhere else, what can happen? Imagine you are having, say, a leak in this particular air cylinder. Oxygen is going to travel like this. Some oxygen is going to go downstream and oxygen is going to go leak down. Imagine again you're having an oxygen cylinder here, and then again you can have a leak here. Now, if you place oxygen here at this particular point of time, even if you are having some leak, you will still administer a lot of oxygen to the patient without leading the patient to hypoxia, right? So these three gases can be arranged in four ways. The correct way should always be having oxygen at the end point nearer towards the common gas outlet. Most of the anesthesia machines are right-sided machines. So the common gas outlet will be at the rightmost end. So oxygen should be placed at the rightmost end of your flow meter assembly. And that is why this is the right arrangement. You can expect a question. They can give you such four images because these can be arranged in four important ways. So they can give you four images showing the flow meter assembly and then tell you what would be the correct arrangement of flow meter. In fact, this question has already been asked. So please do remember, oxygen should always come downstream or oxygen should always come closest to the common gas outlet. Why it should be like that? Because if you are placing oxygen somewhere other than this particular position, and if there is some kind of a flow meter malfunction, you can administer a gas mixture to the patient that might contain very low amounts of oxygen. Okay, so that is all about flow meter understanding. Now, if you have understood everything about flow meters, let me just take you back to this question. Now, I told you that all of the following facts are true about flow meters except the flow in the lower parts of the flow meter depends on the viscosity. Obviously, yes, because you know that in the lower parts, the flow is going to be laminar. And you know that in laminar aspects, the Hagen-Poiseuille law is important, and know that your laminar flow depends on the viscosity. The flow in the upper part of the tube depends on density, obviously, because in the upper parts of the tube, you are having turbulent flow. So you are obviously going to have what? Density dependent flow. Now, that flow meters that we use is variable pressure, variable orifice device. No, we are using constant pressure, variable orifice device. Constant pressure means what? It is constant pressure drop, and the size of the annular opening is varying from the narrow aspects to the wide aspects of the tube. So it is variable orifice flow meters. And finally, in a flow meter arrangement containing air, oxygen, and nitrous oxide, oxygen should always be placed closest to the common gas outlet. Just true. I'll just show you the image. And then significance is it prevents hypoxia from happening. And if in case you place oxygen upstream away from the common gas outlet, there is always a chance that you might administer hypoxic mixture to the patient where the oxygen concentration is less. Okay, so I hope this question is clear. Last point, your flow meters that we are using is otherwise called as TOPS tube. So if they are asking THORPE''S, TOPS tube. So it is constant pressure variable orifice flow meter. It is otherwise called as TOPS tube. So this can also be a question. If in a TOPS tube arrangement, if they ask or if they mention this word in the question, you should not be confused. Okay. So that is all about your low pressure system. This is the only question which can come from your low pressure system. We have one or two few MCQs which are left in your anesthesia machine, which we will discuss subsequently. Tomorrow I'll come with a fresh pharmacology question in anesthesia. I hope you enjoyed this discussion. Thank you.